board meeting for Ashford St Peters, and a very, very important part, because we do the either a staff story or a patient story, and I'm delighted to say that we've got a patient story today. So I'm going to hand over to Charlotte first to introduce Sophie and the story. Thanks.
Thanks, Andy. I'm delighted to have with us today Sophie Mansell, who has a really impactful story about her experience at Ashford and St Peter's within our maternity services. So really relevant story today. And so I'm sure you'll join with me in welcoming Sophie. Sophie, thank you for you stepped up to the plate at the last minute. And what you have to say is really, really, really valuable. So over to you. Thank you.
Thank you. Hello. So just a quick background. Sorry if I have to keep darting. My little one is down here, so I apologise. So my first pregnancy, he will be 2 next week. It was low risk the whole pregnancy. I enjoyed being pregnant. Lockdown hit about 2 weeks before my due date, so appointments were just over the phone unless they needed to be face to face. I was booked in for a sweep, which I went for, all fine, and then had quite a significant bleed that evening. So I was told to go into triage, which I did, and they said they wanted to induce me and deliver the baby as quick as possible. They found that I had preeclampsia. This actually was my due date, so I think I was quite lucky in that I was 40 weeks. It wasn't any earlier. And then in labour, it transpired that I had HELP, so my blood platelets were extremely low, and my liver function, I think, was tricky. So they delivered the baby, and baby was absolutely fine, thank goodness. And do you know what? Throughout the whole labour, my midwife, Chandra Cruz, did keep reassuring me that baby was fine, baby was fine, baby was fine, which did, even though it was so scary. And my husband was only allowed in towards the later part, obviously because of COVID. Just having that reassurance that the baby was okay and they were monitoring the baby was a real, obviously you can imagine being told that at those late stages, but that baby was fine did make me feel so much better. So baby was delivered, and then unfortunately COVID, my husband had to leave quite soon after, and then I was in hospital for 5 days until I think everything stabilised, and then I was allowed to go home, which was nice. And then we fell pregnant with a lovely surprise about 7 months later. And the care I received, so they called me, Sean McDonald, the consultant, called me and said they'd like to put me under the complex care team for that pregnancy because of what happened with the late preeclampsia and HELP with my first pregnancy. And at first I was quite not scared, but a bit anxious, being told you're being under the complex care team. I was a bit, oh gosh, that sounds a bit worrying. But honestly, I couldn't have been happier with the care I received. I don't know if the name obviously put me off at first, complex care, but I felt so incredibly lucky. I had the same 2 midwives for every appointment, Olivia and Michelle, and the care I received was just outstanding. I understand not every woman can be looked after the way I was, but the difference between my first pregnancy and second, nothing was too much trouble. They were so professional, but also so friendly. They never seemed to be in a rush, and I know you guys are absolutely rushed off your feet and so busy, but nothing was too much trouble. They were so caring and kind, and they knew my whole background with my first pregnancy and labour, so I didn't have to remind them of what had happened. They were almost one step ahead at every appointment. And then I was lucky enough to have Olivia on the labour ward when I went into labour the second time round, and thank goodness I didn't get preeclampsia or HELP again. But there were more appointments, which I was so grateful for, because they did put my mind at ease by sort of saying, if anything was to happen again, we will catch it, because we're seeing you so frequently and so often. So at the time, obviously going back to work and having a little one, there was a lot of appointments, but I was so grateful for them. I was so nervous and so anxious second time round, having such a tricky delivery and then being stuck in hospital. That was the last thing I wanted. So I just I will sing and shout about the care I received for as long as I can. And if we ever have a third, I would happily go under the complex care team. As scary as it sounded at first, the care I received was just, it really was outstanding. It really was.
Brilliant, Sophie. Thank you so much.
Oh, you're welcome.
Really helpful.
Thank you. Nice to hear your little one in the background.
Yes, having a little chat.
So we've been talking this morning on our closed board meeting about maternity as it happens, and obviously, you'll have seen all the press yesterday about the issues that the Ockenden report things. What did you think of our kind of we were talking about estates this morning, and because the Labour ward we think is a bit tired, probably needs a bit. What did that impact you at all? What did you feel about that?
Well, the report yesterday did actually bring me to tears, because I said to Charlotte yesterday, I think I could have easily fallen through the net with my second pregnancy. I was so lucky, like I said, to be on the complex care team, but had I have been missed, I wouldn't have been. I'm not the type of person to call and pressure you guys, knowing how busy you are and saying, I need more appointments, I need this, I need that. So it really did, it made me quite emotional reading the report yesterday. But yes, sorry, the Labour ward. Yeah, I was lucky enough to be in one of the home to home rooms. Is that what they're called? Yes, I was lucky enough to be in one of those the second time round, which was amazing. It was a great size. It had the pool in there. But I do think Labour ward in general, yes, could probably do with a little bit of update and just make it, it's daunting, isn't it, going in to have a baby. So when you see things looking a little tired, maybe a bit scruffy, you do feel a bit, it could be a little bit
okay
makeover.
Right,
the nicest way possible.
So if I could ask people, I'm going to bring people in now with their questions, and if I could ask them to introduce themselves when they do so you know who you're talking to. So I'm going to kick off with John.
Hello, Sophie. It's great to hear a very positive message. I'm John Machin. I'm a new non-executive director.
Hi there.
So I am interested in terms of things that you said there, certainly in terms of the anxiety that you felt around just the naming of the team. So I just wondered, are there other things around your experience that we could have done better? It sounds a very positive experience anyway. But are there any other things? I mean, obviously Andy's just asked you about the estates, but are there other things that could be improved?
I don't know. The second time I was, compared to the first time, obviously COVID was, you were all following the rules and things, but it was such a traumatic experience being, having such a traumatic delivery and then being in hospital for 5 days without any visitors and not many other women on the ward. It was an awful experience. I'm surprised we fell pregnant the second time, and I was nervous. I was scared to go in again, but I think anything was better than my first experience and my first delivery. So it was just having my husband there and being able to stay and being able to come back the next day. It felt amazing compared to the first time. No, honestly, it was the midwives that came out afterwards. I felt like I had great care, even after delivery. No, I was really quite happy.
Thank you.
Okay, Jane.
Hi, Sophie.
Hi
I'm
there.
Jane. I'm one of the
Hi.
non-executives as well, and actually I'm the maternity safety champion.
Oh, hi.
So I have a particular passion and interest in maternity services.
Yes.
And it's really good to hear about your experience. And what struck me is the importance of that continuity of care with the midwives that you built a relationship with.
Yes.
And I think for women, people underestimate just how important that relationship with your midwife is. And that midwife that knows you and knows your history, as you described, is so fundamental and key. And I think sadly for some women that isn't their experience, and because of the challenges that we're experiencing in lots of other maternity services, some women haven't had the luck of that. But I think you really articulate very well the value, the added value that gave you. So thank you very much for that. And I think your points about the labour ward, you were very kind, because we know it is pretty shabby in places. So thank you for being so kind. But it's an area that we recognise does need, and we were talking about that in the closed board, that we know that our infrastructure and our environment of care is not as we would wish. So you were very kind about that, but it is something that we really do need to focus on. So and thank you for sharing your experience. It's really valuable here.
Oh, you're welcome. You're welcome.
Thank you, Jane. Dami.
Thank you, Sophie. My name's Dami. I'm one of the non-executive directors, and a bit like you, I've just had a baby just under 6 months ago. I just want to say thank you for sharing this experience, because as Jane has said, it really highlighted the positive impact that it had on your well-being and your feeling of anxiety, just having that continuity of care and the close monitoring that you had, albeit being in your second pregnancy, because normally that doesn't happen. You don't have as many appointments in your second pregnancy as you do with your first, but in this case you did. And thank you for highlighting also or raising the point about, those women who aren't quite as fortunate as you, who seem to fall through the net. It's really quite topical for us, and it's a really good time to have you on board today. Thank you.
No, you're welcome. I'm speaking to friends that have had babies. I feel guilty almost saying that I had the same two midwives the whole way through, because they've seen a number of different midwives on their appointments. They might not see the same one. Every appointment might be somebody different. And I just felt so incredibly lucky that I didn't have to keep telling my story and keep telling them my worries, or keep saying, oh, well, this happened before, so I'm nervous or worried or anxious. They knew, and they would almost preempt any questions. Some appointments, it was lovely to see you, that's it. It was almost like a friendship. We developed a really lovely relationship, and I had to look forward to the appointment some days, because they were just so great. And I felt like I could be really honest with them. It wasn't, oh, here's another midwife. I understand how busy you are, and obviously, but I can't tell you how incredibly lucky I felt the second pregnancy.
Thanks, Dami. Aaron.
Thank you, Sophie. That was really, really insightful to hear. I too have had a baby recently. Well, not me, my wife obviously has had a baby recently. And I think two things struck me from your story. Is that the importance of the relationships that you built along the way, and also during giving birth, which obviously helped massively. So I think that's a key takeaway. And the second point was, I was really happy to hear about the thread of continuity, because as you said, you had HELLP syndrome, and that's a key point to note for your subsequent pregnancy, and the fact that was remembered, and then a kind of uninitiated, unprompted response to make sure that you were well tracked on the second pregnancy is really, really brilliant to hear. So I'm really happy about that. Thank you.
You're welcome.
Sophie, it's Andy again. So could I ask you about, you've talked a lot about the midwives. What about the kind of medical interventions you had, the doctors, the obstetricians? Did you have a lot to do with them, and any sort of comments on was that the right level? Was it at the right time? Could you have done just your thoughts on the
Yes.
medical side.
So I met Sean McDonald, obviously in my first in labour. Sorry. In labour, she obviously came in as one of the consultants, and then amazing. Once I was pregnant, she wrote to me, which was amazing. You think she must see thousands of patients, so it was so nice that she said, you know, I'd happily have you under my care in your next pregnancy. And I just thought, oh my gosh, this is amazing. And then I spoke to her on the phone so many times. I'm a teacher, so obviously I used to say, oh, I can only speak at lunch times or break times, and she was always so flexible and would just call me whenever I said I could speak to her. It was obviously sometimes quite difficult for me to get in, so sometimes it was just a telephone conversation, but she again was so open and so clear, and every sort of step of the way you said, yep, everything's looking good, we'll have a look again in, you know, after next appointment. So I had quite a lot to do with Sian, which was yeah, fantastic. Again, I felt so lucky that she was given the time. Again, she must be so super busy, as you all are, but to, you know, pick up the phone and chat with me, as well as all the appointments with the midwives, having the consultant call me as well and check in. And obviously the midwives had spoken to her because she always knew where I was at and what was going on, and just felt in really safe hands compared to the first pregnancy, which it was just pretty terrifying. I just I thought it's not going to get to that point. I'm being so well looked after. That won't happen again, hopefully.
No. And did you get post-birth? Did you think you had the support you needed?
Well, obviously, again, first time lockdown, I had one midwife visit, which was just, again, it was terrifying. I was at home with my husband after 5 days in hospital, still feeling pretty weak and obviously extremely tired. Had a newborn baby, no family able to visit. My husband then was going off to work, and I had days where I thought, my goodness, my blood pressure must be sky high, and it was petrifying. And then just having one midwife visit and then everything else over the phone, it was a really, really tough time, a really hard time. So then again, this time round, everything was just so much better. I had Michelle and Olivia, so they were my two midwives throughout the pregnancy. Olivia delivered the baby, and then she actually came with Michelle, I think it was the day 5 visit or day 7 visit. She actually came with Michelle here to our house, which was just amazing. I just couldn't believe that the same two midwives that had seen me for 9 months and delivered the baby were then here. And it was just, I bought them both a bottle of champagne because it was just so nice to see. I just couldn't thank them enough. I think comparing, it's hard not to compare, because the first experience was so awful. This was just amazing. It really, so the aftercare, was fantastic. We went into the hospital, I think day 3 for the visit, because I think it was a Sunday, and then after that they came here to us, which was just, I was very, very impressed.
Great. Okay, thank you, Sophie. And it's interesting, the midwives are so critical, because my daughter gave birth 9 months ago in Cambodia.
Oh wow.
Which was an entirely different experience by C-section out there, and of course no midwife support whatsoever afterwards. No. And I have to say, one of our wonderful midwives in her own time then phoned my daughter and gave her some advice, which I was deeply appreciative of. Okay. So any other questions for Sophie while we've got her on here? No, I think you've. Oh, David. Good, David.
Well, Sophie, it wasn't a question. It was just a thank you, really, for coming and telling your story. It's really good for us, and we've had a long chat about maternity in the morning session, and it's really great to hear from you. It's lovely to hear your great experience, and it's just to say it makes me really proud of my staff, actually, and thank you for telling your story. So thank you very much.
Oh, you're welcome. You should be extremely proud. It was I can't say enough good things. Thank you.
Just to let you know, David is our interim chief exec, and his day job is the medical director. So So he's very interested in this.
Good.
Thank you.
Ellen.
Thank you. I mean, it's just wonderful to hear all of that, and thank you for sharing that, as David and others have said. My question is might be more for Charlotte, actually. I'm not sure, but my question is: does this wonderful experience is it also shared with our staff directly in the maternity unit?
So Sophie's story came to me via the maternity team, who had identified her as somebody who had a great story to tell. So I think it has been shared, but I don't know how widely it's been shared. So maybe, Sophie, we can talk about that, and how we can make sure that others hear what you have to say.
Yeah.
I sent an email afterwards to, I think, a lady called Gemma.
Yeah, that's right.
Yes,
Yeah.
and I think she said it would be shared with the two girls and the team. Which, I mean, I can imagine you guys get a mix of stories, but I just wanted to, thank you all, and I was just so grateful. So
Lovely.
Yeah.
Thank you. Thank you.
Thanks, Sophie.
Dami.
Sorry, it was just. Can you hear me?
Yep.
Sorry, it was just to buttress Charlotte's point, really. I think at a time like this, it would be really helpful for the entire maternity team to hear your story, Sophie. I think it would really boost morale and remind them of what a great job that they're doing.
Oh, yeah.
Thank you.
No, you're welcome. You're welcome. Thank you all.
Thanks, Dami. I'll work with the comms team, and maybe we can create Sophie's story and then share that widely.
So Sophie, I'd like to thank you first of all for coming on, taking the time, and lovely to hear your children in the background as well.
Just one of them today.
and also we had a tough talk this morning because of staffing challenges around maternity, and you've really, I think, improved our morale.
Oh, good.
And hence some of the questions about making sure that that's fed back to the team, because they are really up against it with staffing at the moment. So thank you ever so much. You're more than welcome to stay on. It's an open board meeting, but I imagine you've got nicer things to do.
Yes, I mean, a little one just to keep entertained. But thank you so much. Thank you.
Thank you, Sophie. Bye-bye.
Thank you. Bye.
Bye-bye.
Bye.
Thank you. Bye-bye.
Well done, Charlotte. That was a really interesting story. Charlotte's gone. Okay, so reflections on that. That was interesting, wasn't it? Given it's the counterpoint. John.
No, I think it was a very good counterpoint to the discussions that we had this morning. And I do think it's that thing about keeping the patient and their views in mind, really. I know there's obviously great struggles and strains, and I felt, equally emotional this morning in the closed board. But you can lose sight of some of those things, can't you, when you're going through a crisis. But to hear that and then to share that story around the rest of the maternity team, I think would be great as a morale boost.
Yeah, and I'm sure Gemma did. If it went to her, she will have shared it around the team. I know, but I think saying that has been presented to open board.
Yeah.
Will also, if when we feed that back, if we can go back to Charlotte, just to make sure that that the board were really appreciative of the story and the care that they were showing to one of our patients here.
It's an amazing piece of juxtaposition, I think.
Yeah, exactly. David.
Well, I was going to make that point, John. I mean, it is an amazing piece of juxtaposition, and I think the two things that it brought home to me was how great is the ambition of our staff on the quality of care they want to deliver. Absolutely amazing. And the other thing that it brought home to me is, and we did have a brief discussion about the Ockenden recommendations and the continuity pathway, and it just demonstrates actually how important that is. So I just thought, particularly after the discussion this morning, it was absolutely timely to have this discussion as well, and I think it gave a different voice from the staff as well about what their ambition is.
Yeah, very, very good indeed. Andrew.
Yeah, I mean, obviously that was a really encouraging story, Andy, and very encouraging. I mean, from the conversation this morning, I mean, there are real challenges in this area, not just at Ashford and St Peter's nationally. And I was encouraged that obviously it's been difficult in the pandemic, that the walking of the wards and meeting people and all of that stuff is coming back on track, and that's really, really important. I just wondered sometimes on these things whether it's also possible in a board meeting, maybe it needs to be in the closed session so people can be very open and things, whether with staff and certain people where things have been more challenging or certain things haven't worked. Sometimes it might be because of the very nature of, I don't know, pay, the processes, so that the board gets a real 360-degree view of what is happening, some of which has nothing to do with Ashford and St Peter's, but has to do with systems and processes nationally, so that you get all the stories about it, and particularly what the real frontline feel for things are of staff. Because I think also that might build confidence in staff that the whole team of the hospital is on their case, actually. And I know the last time and I can't remember the person, during the pandemic, we had a midwife came and speak to the board, who I also thought was really excellent. I can't remember her name, Andy. But just opening up the conversation so we get the good and the difficult, and so that there's a really informed conversation going on about the challenges of this space.
And I think, I mean, over the kind of 4.5 years I've been here, we've had staff stories like this one, which are, patient stories like this one, which have been very positive, and very difficult ones as well.
Yeah.
And equally on staff stories, we've had staff stories of, you know, harassment, and we've had staff stories that have been very positive. And I think we always give the person, either the patient or the staff, the option of whether they want it in closed or open board, with our preference being open board, because I think the public have a right to know.
Yeah, I agree.
Yeah, and I think it'll be a staff story next time, Louise, won't it? So we can have a think about who we want to come, really. So so it's a good point, Andrew. Thank you. Any other reflections? Did show how tough COVID was, didn't it? You know, on our patients as well. She didn't dwell on it, but my goodness, you know, only having her husband there for the very last bit must have been very tough on her. Jane.
I think, following on from what many have said, I think in my role as maternity champion, as you know, we've had a discussion earlier around the challenges within our own trust, but regionally on maternity services, and on the difficulties in recruiting, because there is a shortfall of midwives, and that causes pressure in the system. And I think what we need to celebrate is what David said, is that despite the pressures, our staff are focused on focusing on providing a quality service as much as they possibly can. And I think we really need to applaud them for that, because it's at their own expense that they do that often. You know, they come in and they cover, and they work longer hours because they want to look after people. And I think we really need to get that message out, that we really appreciate staff doing that, because it's hard, and it's been very hard for them over the last couple of years because of COVID, but they have continued and endured. And I think that's really to be applauded. And we need to really let them know that is really appreciated.
Maybe we could have a board slot on one of the team talks, just to get some of those messages over. You know, the exec team do it all the time, of course, but that the board as a whole, you know, are so appreciative. Maybe we could do that, David. Okay, right, let's move on. I thought that was very, very helpful and very apposite. So thank you for getting that arranged. So any declarations of interest, please, in anything that's on the agenda? No. Apologies, Sal?
Yes, we have apologies from Merrick Favors, non-executive director, and Andrea Lewis, chief nurse, and Ellen Bull is our deputy chief nurse, and she's here representing Andrea.
Okay, and so welcome to Ellen, representing Andrea. Welcome to John Machin to his first open board meeting. as an associate, Ned and John will take over from Merrick when Merrick reaches the end of his tenure in July. Welcome to Ian Smith, who is chair of the Integrated Care Board, or will be when the Integrated Care Board is formally passed through Parliament, hopefully in July. So we're delighted to have you here, Ian, and look forward to listening to you later. Also welcome to Jimmy Squire-Dean, who's sitting in on the board, who's the Divisional Chief Nurse for Urgent and Emergency Care, and welcome to our governor representatives. We always welcome governors and members of the public to this meeting. And if I've forgotten anybody, I apologise. Okay, so let's go on now to the draft minutes from February. So we had a whole 17 pages of them, so we must have had a good discussion in February. And I will just take comments. I'll do this on a page by page because they're so long, just in case. So page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, halfway there, 11, and 12, 13, 14, 15, 16, and finally 17. So no comments. So Liz is off with COVID at the moment, but please, I'll pass our congratulations on to Liz for a good set of minutes. Okay, we move on to actions arising, and the first one was the consider, it's closed action, consider including information on speaking up and induction events. There's a comment that this is being progressed with learning and development. I guess the only question I've got is, has it been done, or is it in progress, or is it just being discussed? So from a board point of view, I'd just like to know that that is going to happen. So Louise? Is Louise there?
I'll have to come back to you. I am here, sorry. I was just looking at the action again. I'll have to come back to you to confirm it's been done.
Yeah, could you do that? Yeah, thank you. Lag in reporting, I think that's comments fine. Assurance summary on the indicators in the report. Yes, it's redesigned, good. Reference made to the patient's story, and that's been actioned as well. Okay. Board walkabouts. So we were going to have this meeting face to face, but because of the COVID situation in the hospital, David advised with his Dipsy hat on that really, number one, it wouldn't be the right thing in terms of setting a precedent when other large meetings are not happening, and B, obviously, because of the current COVID situation. We'll obviously keep that under review. But I do think, David, that we ought to now start planning to reintroduce walkabouts, because I think we'll hear, we've got Deloitte's well-led feedback this afternoon, and we know that they're going to say something about visibility of non-execs in particular, but execs as well. And I wondered if we could get that plan in April and start executing in May, David?
Yeah, so we had a discussion about this, didn't we, Andy? And
yeah,
what we think is we have to have a clear policy, for want of a better word, so the whole organisation knows actually what things are good to reinstate, what's the criteria in terms of the importance of a meeting, the size of a meeting, the environment that the meeting's been held in. So all the organisation can have a look at it and plan their restarting where it is, and not it being centred around special board activities, as it were. I think that's what we were just hoping. So I think we'll hear from the well-led, and we've heard already from the closed and now the open that actually engagement is very important with the staff. We've just got to make sure we do that in a structured way. So Ellen, I just wonder whether you could help me with that, that we start putting together some plans on how we restart that and circulate that. Would that be all right, Andy?
Yes, that will be fine. And as I say, you know, let's give ourselves a month's grace to plan that. But if we can plan to sort of restart, and you know, and whether it's exec and non-exec, certainly the non-execs in the non-exec meeting this morning were all in favour of restarting that, but we have to do it safely. So that's the main thing. Okay, thank you. And the staff story, yep, that's on closed, and the quality report consideration, we've talked about board walkarounds, so that's on the agenda. Okay, I think that covers it. So we'll move on now to my report. Well, take it as read, of course. It was good that we are having a well-led review by Deloitte, and they'll be feeding back to the board this afternoon. David and I and Andrea actually and Sal had a precursor meeting with them, and so you know there's some good things and there's some things to consider, which is what we employ them for. So that we look forward to doing that this afternoon. The visit by Julie Smith, the Chief Exec Designate, happened. I think she reported back she was absolutely exhausted after the day. She'd met so many people. We'd programmed her from dawn to dusk in both hospitals virtually. But she was very positive about her visit and the people she'd met, etc., and looking forward to joining us. And she will be doing a further visit next week on the 8th of April to meet the people she hasn't met already. And the idea was that she met the exec team, of course, the non-execs, and the lead governor she met, and also divisional triumvirates. Just so it was really a very people-focused initial meetings. Surrey Elective Centre, I'm sure we'll come back to that in David's report, but we're now doing the full business case for that. And the Surrey Safe Care, huge amount of effort going on at the moment. And also it's a really tough thing for staff when they're so busy to also have to do the training. So real big thanks, I think, on behalf of the board for that. And then I've just included a selection of photos and internal events, things that been doing. One of those really exciting ones was with Marcine and Andrea there, breaking ground on the Eternal Garden, and we're really so grateful to the League of Friends for making that donation that's making it happen. It is happening. I went to have a look at it yesterday. There were about four or five workmen in there doing their stuff, and hopefully we'll open that on the 28th of April. And thanks to Marcine for championing that from a non-exec point of view as part of the Healing Arts programme. And also we've reinstated the COVID Star presentations and the book, and I went to Woking Hospital, talked to colleagues there. And you know, the education, well, it goes from strength to strength, doesn't it? You know, the new facilities are just fantastic. Great use of space. Our catering staff are so enthused by it, which is really great to see. And the food that comes out the other end is also fine. And just wanted to say at the very end of the report there, I said something about consultant panels, because we had a couple of radiologists, and we've 3 very good recruits coming on stream there. But actually this week we had another one for an intensive care consultant, and that was a great great interview as well, and I think we've made a really good choice, and I think the person involved will also make a difference. So we are attracting some very, very good people to the trust, which I'm very, very encouraged about, and I think they'll all make a big difference. So I'll stop there before my voice gives out completely, and anybody has any questions, I'm happy to answer them. Okay, in which case we'll hand over to David for your Chief Exec report.
Thank you, Andy. So again, I will take this as read and just direct you to where we could focus. So this is a report which summarises the risk in the organisation. And when I took on the interim role, there were three particular areas that I was going to focus on. Four, if you look at the data strategy as well. And this is the first part of just informing you on what we're putting together in those areas. So, not surprisingly, the first risk is people, which is clearly Louise is being kept incredibly busy in our people strategy. And what it does show is what we know is that our staff are extremely tired and weary from the pandemic, from the workload, from the never-ending pressure, in that the end of COVID has been predicted on a number of occasions, and there's nothing worse than when the end has been cancelled. So our staff have been under enormous pressure. The CQC visit, I think, was a really important step as well, and they looked at some of the unhappiness of our staff within theatres, and I suppose some of that predates, well, quite a lot of that predates COVID. So there's the pandemic, which is overlying some other issues that we've had, and I'm just outlining there the huge amount of work that Louise and her team are driving in looking after the well-being of our organisation. There is a specific CQC action plan as well, which I think is later on in the agenda. And also, I draw you to the piece that I think is really important, and that's the people processes which Louise is engaging with. And I really think this is a really important and fundamental piece of work with our organisation. And this is looking at the policies and processes where we manage our staff, or where there are issues regarding our staff, whether they have concerns or there's concerns about their practice, and how we manage that in an equitable way. And I think this is really fundamental, and I'm really absolutely delighted that Louise is engaged with this route. What we're going to work on together, myself and Louise, on this is, as you can see, there is a lot of projects that are going on, and what we need to work out is actually what are the timelines on these projects, when we will see they will come to fruition, and what are the key performance indicators that actually match their progress. And that's not an easy task actually, but that's what we're going to attempt to do, to work on that. The other area is clearly operational performance and elective recovery, and as we've heard from patients and from staff as well, that we do have a huge backlog both within our organisation, although our teams have done amazingly well. I know that James will highlight the fact that our organisation is doing well in this, but clearly there's still a great deal of backlog that we need to catch up with. And what this piece of work outlines is that if we're going to use our infrastructure to its greatest potential, we do have to do, again in Louise's agenda, but James is leading this piece of work, but there's an enormous amount of workforce transformation in transforming the way we operate and the way we plan. And that does need an enormous amount of engagement with our staff, and we need to understand the effect that it has on them. So that is a really important piece of work. And already we've started having a list from Royal Surrey clinicians coming over and operating in Ashford when we restarted some work. The longer term plan. So the longer term plan is extending and evolving the Ashford Centre, and there is plans to bring the two more theatres online, along with the workforce transformation, and add a further two theatres and 2 endoscopy suites at the front of the hospital. And as people know, we did have initial discussions with Anne Eden. We've had further discussions with the team, and this has identified that actually the plan would take a bid of 35 million, and we need to put in a full business case to secure that fully. But clearly they are very keen that we go through that. I know that people, because in the capital cap, one of the most important things that I asked Anne Eden when we first met her in this doesn't fall within the capital cap, so this does not affect the other capital spends, which I think is important. So that's an important piece of work that is going through. And the third bit is the emergency pathway, and I just want to pull you to where we think the drivers in this are. Clearly, we've seen the attendances in our A&E have risen dramatically over the last couple of years. During the initial parts of the pandemic, it was quiet, but now we are more than 10% above the attendance that we previously had. And clearly that puts stresses and strains on our staff. But we have also established the ambulatory care floor next to A&E and also the clinical assessment unit. So that's a huge infrastructure build, which gives absolutely great facilities for both patients and staff to work in. What we need to now work on, and Tom is leading this piece of work, is how we change our clinical pathways. And it's good to have Jimmy on this call as well, because Jimmy is one of the key people in changing how we look after patients when they attend, and how we can reduce the burden on the staff in our department. And I suppose that what the main effort is about, that we talked about a long time, is that what we need to understand is that attending at A&E, what we need to really do is see if we can meet the needs of the patients and return them to their home or their loved ones as soon as possible, rather than to bring them into the organisation, which does have risks attached to it, particularly if we are not delivering some intervention. So that's the aim on this piece. There's clearly a huge amount of work outside the organisation. We've been working with Jack about how the community can help with the facilities that are needed to look after patients in the community. So they're the three areas, and basically what we now need to work on is what are the key performance indicators that we need to monitor through the board, and what's the timeline of delivery of these things, and that's what we're working on all those. I'm sure Simon's going to talk about the digital and data strategy, so I won't dwell on that, but we do need to cover that later on. There is an additional piece which is outside Cerner, which is how we can use patient data to drive change within the system. And I don't know whether you want to deal with finance at the moment, Andy, or I think probably we'll touch on that later on, won't we? With the modern healthcare minutes, I think.
Yeah, we'll touch on it there. Yeah.
So in part two, Andy, I mean, you really stole all my pieces there, which I'm very happy about. But just to reiterate, I mean, the Edu Kitchen, and in fact, I had a tour around the kitchen, and it wasn't because I really had enough time to go around the kitchen, but they just insisted because they wanted to show it off, and they are incredibly proud of it. And they made me walk around the flows of food in that kitchen. So it is absolutely lovely to see. It's also lovely to see the ambition of the staff there, because that ambition does not stop there. So the ambition is to repeat that facility in Ashford, and I know plans are well addressed to do that. And Ralph has said to me we'll have the same kind of coffee bar and the same kitchen has been put in place. And in fact, he wants a larger kitchen because he's got other ambitions about patient catering. And I think the other bit is that we now have people coming to have work experience in the kitchen from the schools. We are planning on apprenticeships and career structures, and he's trying to move on. And he's training the staff so they can take on the Ashford thing. So I think it's an absolutely amazing thing. So it's just worth repeating twice. And clearly, Marcin would, I need to mention the Eternal Garden. I think that's really good. I saw this picture, and it was good to get Marcin actually digging the foundations. I thought that was a really good step forward to reducing the cost of the garden, but it's an absolutely great thing. So well done. I'll leave it there, and I'm happy to take some questions.
Thank you, David. And yeah, that EduKitchen, I think for me, it's the power of bringing a previously outsourced facility in-house. And because we recruited the right person in Ralph, a professional chef, the transformation has been amazing. And whereas in an outsourced facility, everybody has their job and sticks to it, you know, rotating people, training people, bringing people on. It's a really good case study.
Yeah, I mean, there are a couple of things about that, because I think you're absolutely right, and I think that we had lots of discussions at executive level when Simon was starting and putting this in place and everything, and it was about securing the right level of investment to mean that actually it had the quality to meet the ambitions of the staff who are working there, and also to make the staff in the hospital feel that it was a really great place to go and sit down and have a great meal. As you probably also know, and Louise is leading this, Ben Spencer has asked us to submit something to the Parliamentary Awards, and this will form a great deal part of that, along with a lot of the other health and wellbeing strategies that we've been putting in the organisation. So there's a huge amount of work. That's a really good opportunity, and I know Louise is very excited about that.
Yeah, thank you. So let's Marcin first.
More than happy to do the digging for free, David. However, you know it's not me. Thanks for outlining your 4 priorities, which I think after this morning's closed board discussions are obviously so in front of our face in terms of the people and operational pressures. I would just like to get a little feel for how the main effect is actually having an impact. And you talk about the number of patients already you've identified who didn't need to be admitted. Have you actually seen some outcome already? And can you give us any sense of the benefits of that? And secondly, can I reinforce the second part of your paper on KPIs? I will say, when I speak on audit committee, that we did do a deep dive into 2 committees, people and digital, and we do agree as a committee that the next development of the BAF is really evaluating the KPIs and how we affect them forward looking, because they're not actually in cohesion with the risk assessment. So thank you for identifying that. It's something I absolutely agree with you on. But I would like to know just a little bit about the benefits of the main effect and what you've seen so far. Yeah. Thank you.
So thank you about the KPIs, because I think it is really, and it just shines, doesn't it? Because actually the metrics are green in kind of finance, but we know there's a risk around the corner, so they're red, so it's not quite time up. So we do need to do a lot of work on that. In terms of the main effort, what are we seeing? Well, we carried out audits, and as you said, we found out that, and this was not a very rigorous audit. What I mean is that probably the opportunity is much higher than that, but between 10 and 15% of patients would be admitted to the organisation without a criteria to admit. And that's really important that we've got that data now. So that's the opportunity. And I know Tom will want to come in and say, but already we, because we had lots of surge rotors, we took some of our clinicians away from delivering some very important aspects of that, because we had to. And one of those was the frailty unit. And I think, Tom, and you'll have the figures here, but I think the frailty unit has demonstrated that in that cohort of patients, we were reducing the number of admissions from that. And what this is about is making sure that, because it takes a lot more effort to make sure we give the patients what they need to stay safe and get home, rather than put them in a bed and get round to it at a later date and everything. I mean, Tom, have you got the figures on the frailty unit to just give Marcin an idea of that piece of work?
I haven't specifically got the figures, but what we are looking at the moment is the impact. So we're trying to quantify the potential. Can you hear me? Sorry, I seem to have frozen. Yeah, the potential impact of the criteria to admit work, specifically on the frailty pathway. David's outlined what we think is a sort of global position on that, and a high proportion of those admissions will be on the frailty pathway. We've just got some new analysis through this morning, which suggests that there's something like a ward's worth of beds that are being created through this through this process not working effectively at the moment. So we think the impact is around that kind of order of magnitude. So it is pretty significant. And when you talk to the frailty consultants, you know, they believe that they're starting to turn around 3 or 4 patients a day who in the previous when they're on the surge rotor and they weren't able to get to, and in previous ways of working they weren't able to do that. So it is significant numbers of admissions that we could be avoiding. So we need to monitor that very closely, and we need to ensure that we're going to get to that level of benefit. And I'm planning an intervention with the relevant clinical leaders and clinical teams to take place over the next few months, actually, because it will take some time to embed this fully and ensure that we have got a sustainable change of practice in there. And we'll be monitoring admissions to the hospital that didn't have a clear criteria to admit, because we know that that carries risk for those individuals being in hospital when it's not the best place for them to be. We'll be monitoring the impact on length of stay and bed days. We'll be seeking to see a lot more shorter lengths of stay as we work in the clinical assessment unit to turn people around much more quickly and get them back home where they should be. And we'll also be looking at readmissions as a balancing measure, because clearly we want to be sure that they aren't going up as a result of this. But as well as this, the intervention is designed to improve working conditions for our team. And so we will also be monitoring the impact on staff, listening to staff stories, balancing the quantifiable information through KPIs with qualitative information that we're getting from our teams as well. So there'll be a range of things. But as David said, the opportunity we think is pretty significant.
Thanks, Tom. I mean, I think that also plays to a fantastic SIP and to our financial position if we could actually take a ward full of beds out. So well done, and I look forward to seeing the next report. And then, David, if we could actually add in some of the impact and some of these numbers into your next report, that would be great. Thank you.
That's what we're planning to do. And I suppose the thing to get over this is a bit of a cultural transformation about what the purpose of A&E is for. And we've done also quite a lot of work in documenting some of the risk that we expose patients to bring them into hospital unnecessarily. And one of the suggestions at the Quality Committee is actually we do look. I think it was you, Tom. We do look at the harm that happens to patients who needed to be admitted, and the harm that happens to patients who didn't need to be admitted, to kind of quantify that. And we've looked at that. We published quite a few papers. So during the pandemic, what was interesting is that the patients who didn't have COVID, and in those times when we put in place the discharge to assess and all those things were working much smoother, they had a shorter length of stay, they had less readmissions, and they had less mortality and morbidity associated with them. So this shorter length of stay and only bringing people into hospital who need to come into hospital is really important. And what we're trying to do is highlight the harm that's associated if we don't do that to our staff, to change this cultural view of where safety sits.
Thanks, David. John.
Well, it was a follow-up to that, really, because yeah, certainly interested in terms of what the numbers were, and obviously you said what they are now, David, which is great. It was really, though, how do we then do the sort of communications on that so that people don't, so they know what these criteria are, they don't present themselves in the first instance, and they're then in a position where they can be helped or can seek help elsewhere. Are we working on that? Is that already something that's done?
There's two bits here, John. One is that the criteria to admit and the criteria to reside are not something that we've come up at Ashford and St Peter's. They are national criteria, which is really, really helpful. So there's clear criteria about what constitutes someone who needs to be in a hospital inpatient environment. What we've done, what Tom's team has done really well, I think, is starting to embed that when people come in, we've got to document why are we admitting them? You know, what is the purpose of admission? Have they got the criteria to admit? Haven't they got that? That's the cultural change that has happened. And what the national teams are seeing is that this is the thing that we're seeing is very prevalent throughout the whole of the country, and it might be we're a little bit better than some other hospitals, but there clearly is a big opportunity. Now, one of the things that we have to do, that's why we have to work so closely with the system, is that the hospital is open 24 hours a day, 7 days a week, and a lot of people who arrive in at A&E may not need a hospital admission, but they still need care, and they still need looking after, and they still need keeping safe. So what we need to understand with our partners is how can we make sure that is available in the right setting.
Thanks, David. Tom?
Yeah, thanks. Just to add my piece, really, in terms of an answer to John's question. I mean, I think there are two levels for me. One is we clearly need to make improvements in the system to ensure that people are being directed to the right place. I think that continues to be a bit of a challenge out there for us, and we need to continue to seek improvements around that. The second thing is that the issue of when people do arrive in A&E, and how we make that decision and who's involved in that decision needs a lot of looking at. We've done some mapping of how decisions to admit people to hospital are made, it looks more like a kind of sequential process rather than a single event at the moment. And the approach that we've been used to in surgery for a long time is a process of consent, risk assessment, a clear checklist before the surgery actually happens, that kind of thing. And we need to bring some of those same elements in. We need to have honest conversations with people and their families and carers about whether hospital is really the best place for them, given all the risks that a stay in hospital brings. And as a result of that, we may be asking more of families actually and carers to support people at home. And we need to make sure that we can support them to do that. We're looking at developing things like virtual wards as a big program at the moment, and that may be one of the solutions to this potentially, developing more technological solutions to help people and working with our partners in the community to make sure that the staff are available so that they can provide some of those home visits that might be needed. So there's a range of things here, but I think communicating with families and with carers and of course with individuals is an important part of this, and we need to see this more as a seeking their consent, I think, to an intervention that we might think is right for them, whereas in reality, with the information that we now know, it may well not be.
Thanks, Tom. That's very helpful. Okay, so we're going to move on now. Thank you, David, for that. We're moving on to the quality report, and Jane, do you want to give us the quality committee view before we ask Ellen to bring out the main points?
Yes, thank you. We received this report last week at the committee. It is in a new format, and I know that some of the members have had difficulty accessing that, so apologies for that. And obviously we're willing to work on that. I think at the committee and actually in Appendix 2 of the interim Chief Executive's report, you can see that we are failing on a number of our quality targets. And this was something we focused on at the committee to actually seek assurance about what actions were being taken to address the issues in relation to infection prevention and control, falls, pressure damage, and also the gathering of patient feedback, because all of these we are struggling to hit our targets and are failing in many. So I will ask that Ellen actually describes in detail the actions that are being taken, but I just wanted to assure the board that this is an area that the committee will continue to focus on, because quite clearly it's very important that we improve in many of these areas. Thank you. The only thing to probably say is that when we benchmark against many of our peers, they are also struggling in many areas, particularly in relation to infection prevention and control in relation to the pandemic, but also in relation to pressure damage. And there is an association with pressure damage and COVID, which we've talked about at length, and we recognise that that is a challenge and has been a challenge nationally. So some of these areas of concern are compounded by the COVID pandemic, but that given that, it is an area of focus for us at the committee.
Okay, thank you, Jane. So Ellen, if you perhaps focus, Marcin, you want to say something?
Could I just ask Jane, as the chair of the committee, Andy, particularly the one sentence, because I would like to know the committee's response. There is no assurance meeting our quality priorities this year. It's a very strong statement, and I don't actually think it's a correct statement, because you can't have no assurance. You're basically saying, I've given up, there's no mitigation, there is no action, and I can't fix it. And I'm concerned about that sort of language and a misunderstanding of the word assurance. So Jane, I just wondered if the committee had picked that up and had addressed that, because I don't believe you have no assurance, and I don't as a board member.
Yeah, I think that's absolutely fair, that challenge, Marcin, and you're right, we do have assurance around a number of areas. I just think that some of our targets have been a key challenge for us this year. So I think that is something that obviously the committee, you're absolutely right, that is something that the committee, we do have assurance in many areas.
Thanks for that, Marcin, helpful.
Thanks for letting me interrupt, Andy. I just think it's important that our board colleagues understand that we can't possibly have no assurance, and we might as well go home. Okay.
Yeah, no, very, very helpful intervention. Thank you, Marcin. Okay, so Ellen, could you perhaps focus, we'll take the report as read, but focus on the kind of actions, as Jane has suggested, that are in play?
Of course, thank you. If I may just talk a little bit just about the style of the report first. So it was aligned, so Jackie and her team have been trying to align this to the same style as the performance report. And I think that's where the sentences around assurance have come in. But all the feedback is really, really welcome. Thank you. And we'll take that back to the team. So if I focus on, so Andy, Chair, so you just want me to focus on IPC, falls, pressure damage, and feedback. Is that right?
Well, I think focus on the kind of that actions are in place over the things that Jane has raised, and if you want to draw our attention to anything else, obviously, please feel free to do so.
Okay, thank you. So for infection control, COVID, as Jane has already said, does remain a challenge, and that goes up and down with the variable incidence and prevalence externally. But we have got good controls in place in terms of a really strong infection prevention and control team, and really strong visibility at ward level. Both of our infection prevention and control team and our ward managers and matrons doing their daily and their monthly audits. The chain of command around the incident governance, so our bronze and silver command meetings also have a very strong focus on actions that we need to take, and we've been having some stronger conversations and discussions about what else we can do and actions to take forward, and ensuring the daily assurance that we're getting at ward level around other things which are more challenging, such as patients wearing masks, which will help, but it's obviously a big challenge for some patients to wear masks. So we've got some strong actions in place, and obviously updated policies to follow. But when we look at the other infection preventions in the report, we can see that we are within trajectory, and so that's good. That's good. And of course they feature in our quality priorities, which is one of the later papers. In terms of falls, we've had a strong focus on falls through the BDO report, and that has shown us that we need to concentrate on some particular areas of practice, which we are doing and have done, which centre on driving forward our falls risk assessments. And again, we've got strong oversight and processes in place to do checks about the risk assessment being completed, and also supporting staff at the front line to not duplicate the process of doing post-falls risk assessments and the DATEX. So just trying to sort of tease out that actually the post-falls risk assessment is the risk assessment that needs completing, and the DATEX is a reporting mechanism. So they don't need to put both pieces of information in the same place. It just needs one, it just needs one for all the post-falls risk assessment. We've got a really high level falls risks nurse. She's very clinical, and we've got strong actions in place with our areas of focus in terms of where they have the highest instance of falls, and rapid reviews on that where we have those instances as well. Our ward managers are very much wrapped into those actions, and there's a good network of outputs of the audits as well. So we have a daily audit tool and a monthly audit tool, and that gives us clinical assurance about what we're seeing in terms of completion. In terms of pressure damage, so as Jane has said, we have done a check nationally to see if we're an outlier with our incidents, and whilst that's not assurance, it does give us a benchmark as to if it's something that we're doing or not doing clinically. So there is a correlation with our patients and COVID. However, again, there are some instances where this is practice related, and there's a strong focus now on ensuring that we are doing all those details around checking skin. So we have in our nursing documentation, there's a very straightforward to complete risk assessment around pressure damage, and there's some additional documents which are body mapping and skin checks, and our current focus is ensuring that they are done every day and checked and escalated if there are any risks. And our TVN team has currently just remolded so that we've got slightly more hours to play to provide clinically for pressure damage per se. And we've actually, so there's a good recovery plan in place, and we've actually started to see more recently that the incidence is recovering. In terms of patient feedback, there's a trajectory to increase up to 20%, and I do believe that's one of our quality priorities as well. And there's been a measured approach in terms of supporting areas to increase to that target through that timeline. And then the other things to draw out in the actual report are to do with the SSIs. So really good progress has been made on the SSIs, and that continues. And also just to draw out around that sepsis has improved. There's more work to do with some of those bundles, but that has improved. And then just finally, just to draw attention to the healing arts projects with the pictures in AECU and UTC, and the actual pictures are in the report as well. So yeah, I can take some questions.
Thank you, Alan. Any questions for Alan? Marcin.
Sorry, dogs and doorbells. Just to say, Ellen, it's interesting that the feedback for the viewpoint, the reduction in people commenting about the environment, and it's for my board colleagues to know that the Healing Arts Committee put that additional question in a way for us to measure the impact that we're having. So it's interesting, it's outpatients, which is where we're going to focus our next bit of investment in terms of the arts and the environment. And I hope that we get an improved score, because we are getting positive feedback from the areas where we've added the light emitting pictures. So I think that was interesting. And Ellen knows my view, but the falls audit is the one where, you know, we had issues of non-compliance with our own policies, and the report was reported in December, and we haven't seen improvement. So it's something that we know that we had Ellen at the audit committee, and we're pushing for improvements. If we actually have the action and the tools, we want to hopefully see now the compliance and the improvement, because February took a dip, and I'm hoping that that's a one-off dip, and Ellen gets it back on track for March and April and May. So that, just a few comments on the report. Thank you.
Thank you, Marcin. David.
Yeah, I was just going to say, I do like the new format, Ellen, and I know the team have worked really hard, and there does need to be a bit of work, but I do like the way it demonstrates the timescale over where things have moved, and you can see the variation and things like that. So I think that's a really good step forward. I think the surgical site infections, I think we've done some really great work in some places, but clearly identifies other areas where we need to do more work. But actually having surveillance of the SSIs on a continual basis, that is fairly unusual actually in hospitals. I know that the data hasn't been updated since the last quality report, so we do need to wait for that. The other bit I was just going to draw attention to was the mortality, because the mortality went up in December. And actually, when I saw the data about a month ago, it looked like we were tracking above our peers. But actually, the latest data does show that we are tracking with our peers. But we have asked Paul and the team to look at that mortality because of the level there, and that's what we did from the quality report coming forward. So I think that'd be a good piece of work to do as well. Thank you.
Thanks, David. Yes, I was going to look at the SSIs and sort of commend you really to that we've got this level of visibility now, and obviously we are doing well in C-sections and breast, but clearly you've identified others where we seem to be very high really. So good work in progress, but lots to do, I think.
Yeah, I mean, just on the point of that, actually, I mean, I don't remember when we saw the cesarean work being done, that there are two types of infections, which is probably not a very academic thing to say, but the biggest concern is deep infection, so that's in the kind of body cavity. And what we saw was that we eradicated those early rather than the superficial infections. The other thing that's really important is that what they did in women's health is they rang up the women, every woman, after they had a cesarean section to ask them how their wound was. And it's that kind of attention to finding out and looking for the harm that I think is so important. And Anna's doing a brilliant job in terms of the other surgical sites as well, because you have to look for it. And if you look at the GIRF reports, I mean, John Abercrombie came and talked about general surgery, and one of the points he was making that if you don't look for it, you'll miss more than 50% of the infections that are going on. So I think we've got the surveillance right. What we've got to do is now sort the problem out.
Yeah, thank you, David. Shashi?
I was going to say a few things as David mentioned, because we never looked at those incidents, Andy. So now it looks bad. I think the work done by the team is excellent. There has been a lot of improvement over the past 2 years, even though the numbers look as an outlier. But if you look at the trend, the numbers are going down, so which is quite reassuring. But one of the problems with the continuous surveillance is that we don't have any IT technology, because Surrey Safe Care apparently is not going to deliver that. So maybe we need to look into a different kind of a software system which can alert us with ongoing surveillance. So that's something we can take it outside the meeting and then discuss.
Okay, thank you, Shashi. Okay, so let's move on from the quality report then to the quality improvement priorities. So you don't get off, Ellen, yet. Do you want to present those?
Yes, of course. Thank you. So the quality priorities we're presenting here for approval, and it's the annual refresh. So from April this year to March next year. They've been through the usual stakeholder engagement, including CCG and Healthwatch, and match the strategic objectives. They're largely unchanged, but if I just draw out a couple, so medication safety, there's just a further stretch and an addition of medicines reconciliation. I think mortality is largely the same, and that's got an improvement lead and a QI approach that sits around that. And then harm-free care, we've added in the long-standing blood pressure, which is a perennial issue. It's actually on our monthly audit as well. But again, that's, we will drive that forward with practice, but it gives us a measure of where we are. So that's all I was going to say. And obviously they're presented in the chart at the back of the paper.
And Jane, the Quality Committee, happy with these?
Yes, we discussed these, and we were comfortable with these, and we also were pleased to see that they aligned very well with our strategy refresh.
Okay, great, thank you. James?
Thanks, Chair. So one new one that Ellen, you didn't mention was the avoidable harm to patients on waiting lists.
Oh, yes.
The focus on that as part of these quality. So there's generally the NHS has got longer waits ever, and we've got longer waits, than significantly longer than we had. So focusing on this, not the activity of clearance, which is very clearly operational through the performance report, but focusing on the act of keeping people safe, understanding the safety of those people, is something that we've reflected in the priorities here.
Good. Do you need us to approve those, Ellen, or are they for noting?
They're for approval, final approval,
Okay.
having done the stakeholder engagement.
Okay, yeah, because they were down on just as receive.
Sorry.
So are we happy to approve those priorities? Yeah. Okay, good. Thank you. And the CQC action plan.
Of course, yes. So again, this was presented to the Quality of Care Committee and discussed. This is the high-level action plan, progress following our CQC visit at the end of last year, and features the high-level action plan both around shoulds and musts. A conversation at the Quality of Care Committee centred on particular areas of focus, and the three that were discussed, and just to draw your attention to here, are around medical devices, and there's also been a BDO report around medical devices. There's a strong forward plan, exec lead, and robust governance in the form of a medical devices committee that will monitor both the CQC outcomes and the BDO actions. So that's one of them. Staffing, just to say that that's highlighted. Obviously, we've got strong recruitment and retention plans around our staffing, and risk registers where appropriate, with mitigation plans in place. And again, just to draw the attention to the key actions document that we submitted to the committees to put our forward actions in place to for our forecast gaps, and then just our work around culture. So
okay,
yeah.
Jane, anything?
Thank you. We discussed these at the committee. One of the things that we wanted assurance on was that obviously the divisional responsibilities were quite clear, and we had a discussion around ensuring that the divisions were aware of what was within their gift and what they needed to drive forward to make sure that they were signed off, which is really important. And we had the divisions at the a number of the divisions at the meeting again this time, which was really helpful to see that. So it's just important to say that this is not a corporate action plan. This is a whole organisation action plan that needs to go through the whole system.
And Ellen, just before I bring in Martine, does this plan go to CQC as well, or they see something a bit different?
I think this is discussed with them at the regular management meeting. There would have been an upward submission. I'd have to check with Jackie about whether it was this document or if it was something else.
Because I know we had to go back to them with an action plan.
Yes, we do.
Just wondering whether it was a more high-level one or whether this was the one that went. That's all.
I'll have to check with Jackie.
Okay.
I don't want to, you know.
Okay, if you just let me know, that's fine. Marcine?
Chairman, my comments relate to actions items 6 and 7 on mandatory training. I'm concerned that the actions seem to just be have a meeting planned or forward this, when we know from the statistics and the KPIs around mandatory training that we aren't hitting our mark. It is a concern. I know we've got an internal audit starting on this. I just feel that we ought to be a little bit more action oriented with measurable actions on items 6 and 7. It is a concern. I just wondered, Jane, the committee picked that up, or what?
I mean, we require as part of the divisional reports that they do give us data on their mandatory training. So that is something that we do monitor as part of the divisional reports. But we probably need to make that clearer in this action plan, because that is something that we actually get figures on. You're absolutely right, Marcin, which we need. And it is an area that has been an area of focus, because we know that in certain areas, certain training hasn't occurred as it should have done. So I think maybe, Ellen, if we could just strengthen that a little bit and make it clear that we actually do get the data behind that through the divisional reports to the Quality of Care Committee, which we can then monitor and hold to account. Thank you.
And one of the other issues that we identified, or the internal auditor identified, was a lot of our mandatory trainings done at corporate induction. And yet we only have 70% of new starters attending corporate induction. It's not mandatory for everybody. So I think we're missing a trick here. And I think it's an area that hopefully internal audit will pick up, and then the people committee can then follow that through. But Jane, I am concerned that it just feels it's not strong enough, and that we ought to make sure we really are addressing induction mandatory training as a compulsory requirement. Thank you.
Thank you.
It's certainly news to me that induction isn't a mandatory requirement, because I thought everybody went through induction.
It was news to me too, Chairman.
Well, everybody is invited and booked on induction, but we do have a level of people that don't turn up, and I suppose that is the piece that audit identified, that there isn't a robust follow-up with those people.
Right. Okay.
So that's now what I'm looking at.
All right. Thank you, Louise, for that. John.
It was really a follow-up to what Marcin's already just raised. I'm very used in an audit world to actually using these sort of words around. I understand must, very, very clear, but then we start talking about should ensure, and I think to me that then gives you need some form of evidence then that says you are ensuring that in some way. So we need to be very clear what that evidence is. But then it's other things that says should consider. I mean, what does that mean? Well, we've considered it. Can we move on? I find it very difficult to actually understand some of the nuance of how this is expressed, and therefore what's the evidence that's required to then support the actions that are taken.
Auditor, is it us, John? I agree.
It's very, it's open to interpretation, which is not helpful to anybody in certain instances.
I think it's the CQC wording, isn't it?
Yeah.
Yes.
I mean, because they do say should ensure, should consider, should take action. And then, when they say should take action, then clearly you got to know what that action is.
Mm. Interesting. Yeah. Ellen?
No, I was just going to confirm. Yes, it's definitely CQC language, but we treat shoulds like musts. I mean, the priority is musts clearly, but we close shoulds as well. There is as much energy and focus and governance around our shoulds as there are musts, clearly. And just to say about mandatory training, there is a strong focus on mandatory training internally, particularly on our areas that match our risks. So MCA, DOL, safeguarding, we've got a strong process around making sure that we are increasing our compliance around those areas which really affect patient care and show up in risks. But clearly there's work to do on ensuring attendance at mandatory training at induction.
Okay, thank you. Simon.
It was just to add, I mean, clearly you can do most of your mandatory training as kind of e-learning, can't you, and do it online, but there's bound to be an impact for the next few months from Surrey Safe Care and the amount of other training that we're asking people to do. So I think those numbers are going to get worse before they get better again.
You pinched my point that I was going to say at the end, Simon.
Sorry.
No, it's all right. No, right that you should raise it, because we're asking people well, we're really pushing people to do Surrey Safe Care training, rightly so, and it will have an impact because they've only got so many hours in the day. So we need to recognise that. Ellen? Is that an old hand?
Yeah, thank you. No, I was just going to say that we've been knowing that Surrey Safe Care was coming. We've been in nursing midwifery driving a forward plan around mandatory training and planning to try and get that in beforehand. So with that forecast view, but yes, that there will be a competing priority in the coming months. But we do need to have a plan after that, and
Yes.
that's what we've been asking people to do, to make sure that their training is booked.
Okay, David.
Well, it's just. I think it's on John's point really, and it's one of the things that I've been kind of questioning. Thank you, Martin, for bringing up about mandatory training. There's one thing doing the mandatory training, but it's the test of effectiveness. So there are some mechanisms in the hospital. So the perfect ward is an example where we can test the effectiveness. But I think we've got to do more of that to see whether the mandatory training is, even if it's undertaken, is doing what it's designed to do. So it's closing that loop, isn't it? So you do the training and you test whether it's been effective. And I think there's a bit more work to do that. And although the perfect ward is really good, it's not everywhere, Ellen, is it? So it happens on the wards. So we have a lot of other places who aren't wards.
Yeah, it's widened out to outpatients, but there are areas without it, David. Yes, absolutely right.
Okay. All right. Thank you for that. Good visibility of the action plan, and I guess that what we'll need to see is obviously progress against it. You know, when these are closed, so that will come up back up through the quality committee. Okay, thank you. The minutes for January. Anything you want to note, Jane?
They were accepted as an accurate record at the meeting. Pleased to say that at the meeting last week we welcomed back the divisions, which was great because they added great richness to our meeting. So we had urgent and emergency care, diagnostics and therapies. We had the Berkshire Surrey Pathology Services, Women's Health and Paediatrics, and the maternity report. So a wealth of experience and feedback from the divisions, and the committee could then seek assurance around some key target areas. We also, which the board, just to be aware of, we had the End of Life Working Group annual report, which was an interesting report, which really focused on areas of good practice. But one of the areas that we need to improve is recognising when people are entering that end stage of life, actually helping them to make the decisions about where and how their care will be is an area of improvement that we're going to be working on, and that's a wider area. That's a community action. So obviously that needs to be linked across the whole of the region, because people often choose to have community and home care. So that was really important. And just to assure Marcine, as part of the audit committee, that we looked at the action plans following the internal audits on deprivation of liberty, falls, surgical site infections and medical devices, and that was really good to see. We've made quite a lot of progress on those. It's really good to see that we're actually monitoring that, and we will monitor that until they're all completed, but they're all well on progress now, so that was really good to see. And finally, we reviewed our quality of care strategy refresh, which actually linked very closely with our quality priorities. Thank you.
Okay, thanks, Jane. Okay, let's move on to the PASCO report. Jane, have you got anything from a kind of quality committee to add to this? Because it seemed to me that the PASCO report, obviously it was for Southern Health, a huge number of recommendations, and quite a difficult sort of mapping exercise going on.
I think the team did really well. I think what was interesting is obviously this was a little time ago, and actually we reflected at the committee, because we looked at this report, that an awful lot of the recommendations we had already recognised we needed to do internally ourselves, which was a really positive place to be. Obviously there's some areas of improvement, there always are, and areas of learning, but I think we were already culturally in that position of actually looking at the openness, looking at a culture of of speaking to families, involvement with them in the investigations. I think we accept that the duty of candor conversations aren't being recorded as they should be, which we've already talked about in this meeting. So that's something obviously we do need to pick up on. But I think our reflection at the meeting was there were no surprises here. There was no area that we thought, oh my goodness, we've not even thought about this. But it's area that we were already working towards, and I think it's very helpful to have it written out and see exactly where we are.
Thanks, Jane. Ellen, what do you want to bring to our attention particularly?
Thank you. Obviously, just to add to what Jane has already said, of 38 recommendations, and overarchingly, this is how we, this is how we look after people and how we can improve that. And this gives us an opportunity to sort of stand back and create that objective review of how we do what we do. And then just do that mapping and gap analysis exercise, which is here. And again, we'll be providing this back to the Quality of Care Committee for closure of those actions.
Okay, it looks like Head of Patient Experience is going to be busy. She's got quite a few actions there.
Yeah. So obviously that's it's as we did with the CQC, as we said with the CQC action plan. It's a lot of these recommendations really centre on the governance side of drawing in our divisions. So that's where that will be part of what we do and how we do it. It's the governance side of things.
So look, it did look at a very a good piece of work. Anybody got any questions? Because it seemed to align quite well with our quality priorities as well. So no. Okay, let's move on then, because we've got a big agenda today. Learning from mortality. So Shashi, do you want to lead off on this? No, Shashi's got.
Hi,
you're there.
Thank you, Andy. I think we presented it at the Quality of Care Committee meeting last week. I'm happy to take any questions. And following that meeting, I did discuss that with Paul, and he does reassure us about the question raised by Dami and others about the risk-adjusted mortality index, which is we are not an outlier from compared to other trusts. So, but he's taken a few recommendations on board, and he's going to work on how we can include exclusion criteria in there to look at the mortality rate as per equality and diversity point of view. So I'm happy to take any questions.
Thank you, Shashi. Yeah, I found it interesting the all hospital deaths with the COVID ones in different colour was quite interesting, wasn't it? And that's obviously coming to the fore again now, losing people to COVID. Jane.
Yeah, that was an area that we highlighted for further consideration at the next meeting, and David was keen that we did that. I think the other thing that we continue to be frustrated by is the timely reviews of deaths, and we recognise that this hasn't moved forward as it should. There has been some extra resource put into this, so we are hopeful that it will improve, but it's a bit frustrating at the moment because we continually are feeling that we are on the back foot really with our timely reviews. Having said that, the Medical Examiner's Office is doing sterling work in reviewing deaths and also meeting with families and dealing with any of their concerns, and that team have been expanded and are now going to be going more into the community. So that's excellent. So that's something really that we're pleased about. But we continue our focus on the timely structured judgment reviews.
Yeah, absolutely. I agree with you, Jane. I think the SJR, the number of reviewers are increasing now, and then we have a mortality lead in place next week, which we are happy to announce that. And then that mortality lead happens to be a trainer as well. Hopefully that will help us train more reviewers. But I think there are multiple. It's a multifactorial. People are busy with clinical work, increase emergency admissions and restoration work and etc. But yes, hopefully we make some progress by next time.
Okay, David.
It was just a bit of clarity around the deaths due to COVID. So the deaths are recorded if you've had a positive COVID test within 28 days before. So the kind of confusing thing is it doesn't necessarily mean that COVID caused your death all the time. So because it looks worrying, doesn't it, that we're seeing this rise during this time, but we haven't really seen that impact within the hospital. At the moment we've got 2 on ITU, but usually we've been at the order of 1, and a large number of the patients in hospital have got incidental COVID, so it's not what they presented with. If you look at the rates in the communities, to give you an idea, in the southeast, the latest rate, it was up to about 8% of people had COVID at one point. So the volume and the infection rate is incredibly high at the moment.
Yeah. I mean, the one sentence that kind of disturbed me a bit was under where it says agreement was obtained for 30 PAs, but limited interest from SJR reviewers for extra sessions. Maybe that's just a difficult wording, but it kind of sort of, I'm sure it's because they're doing loads of other good things, not because I can't be bothered to do any more. Was that just a wording thing?
No, I'm afraid it's not just a wording, Andy. I think you're absolutely right. People are tired and they are not willing to take any extra work. Even when we offer them extra money, they're not willing to take extra work because they're busy. And yes, one of the ways of we discussed at the meeting and also with Paul is can we include some of the members of the staff, like senior registrars who can do SJRs. So we're looking into that to improve our completion rate. But having said that, unless we have a willingness from the team, it's going to be difficult to achieve that.
There's so much going on, isn't there? Okay, the assessment of care one, I have to say, the 9 days with no nutrition horrified me, that we could actually do that. Oh yes, they're unsafe to swallow food, but there'd been a plan, and how did we miss that? Is just, I'm sure the investigation will bring out all the learnings and things, but it was just horrified me really if that was my relative or me. Jane.
I would absolutely concur. That was a one that I personally raised as an area of concern, and for feedback as soon as possible when the investigation gives us more information. And I particularly wanted assurance that this patient was at least had hydration, at least had fluids. So yes, I too felt some concern around that and asked for further information and was assured that would come to the next meeting.
Okay.
True.
Any other comments on this report? Okay. Chris Ketley, sorry.
I guess also one of the things we discussed, Jane, wasn't it, was that in terms of timeliness, the concern was, with this backlog, what if something untoward was going on? Would we actually identify it? And I get Sashi gave assurance around the procedures in place and the processes that actually safeguard us against that. So we were assured that those safeguards were in place.
Okay, that's helpful. Shashi?
That's true, Chris. I think we discussed that, and there is a system in place where Jackie and her team do go through all mortality cases, and there is an initial investigation done, and then they screen those cases and they apply whether to SIRI or SJR. So, and having discussed with Paul and Jackie, there is a system in place to give us a reassurance that we are not missing anything.
Okay. Thank you. We'll move on in the interest of time. We've now got, finally, we've got the organ donation annual report. Ellen, I actually sit on this committee out of interest, so I can perhaps provide some illumination if anybody needs any as well. Ellen.
Perfect. Thank you very much. So on behalf of Dr. Gill, actually, so this was presented to the Quality of Care Committee and shows, if we look at the key performance metrics, a good performance with donors following neurological death, and which is to be commended, particularly in this challenging time, and good performance in terms of organ donation, which matches a 2018-19 level. And more work to do around the circulatory death, although there we're not an outlier in terms of the regional performance, and that governance throughout COVID has been maintained with good representation and attendance at the overarching committee, and that we've got specialist nurses all in place. So yeah, that's I can take questions, or
Jane?
Chair can.
Yeah, thank you. We did receive this. We were very pleased with the work of the team, and we asked for their committee to extend the thanks. With regards to the circulatory deaths, we were assured that actually the reason that our numbers did not compare with the UK numbers as favourably is because in the southeast they had taken a decision that where it was clear, usually due to COVID, that you would not be able to use the organs, that the conversations were not had with the family in relation to that, and so actually in the southeast the numbers generally are lower than nationally, but I have asked for a little bit more detail on that just to understand what that means. But that was the explanation there, that where it was futile to pursue that, that was the decision. But and it does give a little bit of explanation there, but it is something I've asked for a little bit more clarity.
Yeah. And my view as kind of, if you like, a lay member on this committee is that it really works very well. We have an outstanding, I mean, it sounds awful, the SNOD, the specialist nurse for organ donation, and she's really outstanding, and the working with intensive care in particular is very, very good between her and intensive care. So, you know, it does well. I mean, lesser organ donations this year for some reason, but then they're just not available. You know, the numbers of deaths that fall into the criteria, etc. So I think it's a committee that, you know, and a system that works really well in the background. Okay, good. Thank you for that, Ellen. Right. So we're now going to move on to the performance section. And James, do you want to lead off on that?
Yes, thank you, Chair. I think this section just pulls together a lot of discussion that we've had elsewhere in the meeting, to be honest. The COVID numbers through February, you can see in the report, have impacted performance across the domains. So we've had around 68 people on average in the organisation with COVID through the month of February. That's people with confirmed COVID. We have at least that, if not 1.5, 2 times that, of beds closed due to isolation as well. So at any one time we have between 70 and 100 beds closed, of which up to 20 can be empty, where we can't use because those patients have been exposed to COVID. So if you think that we're running about 150 to 180 beds limited in that way any one time, that begins to explain why we're having challenges through ED and through the elective pathways. So and you can pick that up as you go through the report. You can see that in the length of stay issues that I'll come on to in the organisation. In terms of our elective activity, this is where a significant challenge lies, and as David outlined earlier in his GXO report, you know, we are performing comparatively well to other trusts in the region and nationally, but we still have significant challenge in terms of waiting times. And you can see that the long waits that we're having are beginning to creep up a little bit in terms of our over 52 and our over 90, and that's because of the downtime that we've had during Christmas and the fact that we were bedded into the elective centre at Ashford. At least one of those wards was occupied for overflow or medical step down, and not elective work through the whole of January and February. So that did have an impact. So whilst we are comparatively good, there is challenge, and it does reflect back to the conversation earlier around quality, priority, and keeping patients safe who are waiting. So this does link to so many items that we've discussed today. The obvious one in this section is just I need to outline, it's just outpatient waiting times. We are having significant challenge there, and you can see that in the report. We are not making movement, particularly on the number of patients waiting for a follow-up appointment that is overdue. So we're currently running at 11,300. As you know, we've put in a number of initiatives around this, and you can read them in the report. We've had insourcing, we've done extra clinics, we're aligning locums, we're doing lots of things we can. We're having a particular drive now through the next 12 months on utilisation of clinics as well. This is beginning to be a bit static for us. One of the things we are doing in a few specialties where it's clinically appropriate, we are switching some new slots to follow-up slots where we think there's a greater degree of urgency. So that's happening through April, May and June. But that's still at the moment, we don't have plans of the quantum to shift that. And that relates particularly to 3 or 4 specialties that drive 80% of that or 70% of that work. You can see also in our news, the number of patients, whilst we're focusing on the urgents over 6 weeks, and that's our own standard, we made that one up as just a metric to guide us. We're coming down, but our news over 18 weeks as well, these are new first consultations, are still high. And again, that relates to some particular specialties where, well, we have challenge across the piece, but there are some particular specialties driving that as well. And we picked that up through the quality of care committee also. Let someone get that. In terms of urgent care, we have it's been discussed pretty well, and I think the key things around here are the sustained pressure that we're under. The number of attends, as David said, has gone up by 10%, and that's March has gone up even more actually. We are under sustained pressure in urgent care. It's creating, as you can see in the report, but in reality it creates a real pressure. Patients waiting overnight in A&E, that figure is not moving. On a daily basis, we're having double figure levels of patients waiting overnight in A&E for a bed, just a reflection of the pressure that we're under. The key things around recovery of this are the stuff that Tom's outlined, that David's outlined around the consultant workforce and those pieces that we're doing with CAU and all the work that the divisional teams are leading on. I think finally, just on diagnostics, I just want to pull a few things out. It's just that we have made a turnaround that we said. We have been putting a lot of effort into our non-obstetric ultrasound and our endoscopy. We've been able to, in non-obstetric ultrasound, gain a lot of momentum on plans. So we've been able to have access to quite a lot of bank hours this month. And with our insourcing activity, they're the only two things, the only two solutions we have in non-obstetric ultrasound, which are driven, as you recall, by staffing pressures. Both of those things have worked really well in month, and they've given us a big reduction. However, this is part of a journey, and that 1 month reduction is not being conducted in a way that is sustainable necessarily going forward, because we still haven't rectified the staffing issues, the absence of staff, shortness of staff we have there. Similarly, in endoscopy, big improvement, but it's that sustained improvement we're looking for, and we do expect that number to bounce on a downward trajectory. We have got ongoing issues in imaging, and we've had to look at the number of plain film reports, plain film X-rays that we do and CTs that we do because of radiographer numbers, and because we need to divert radiographers to cover important things. So we have cut down at the moment plain film and CT, and that will affect our DMO1 position in future reports to you. And cancer, after the winter months and the COVID challenges that we had in January, you can see that a significant amount of work has gone in across the piece. We're compliant to 6 out of the 8 cancer standards, so that's been a number of months that we can say we've been compliant to 6, and out of the 2 that we missed, the 31-day standard was missed by 1 patient. So in terms of the cancer performance, we can demonstrate a real sustained, well, not sustained, but a real change in performance, a real grip across the standards, in a way that, you know, we've said that we'd be working on with the capacity work that we said was happening. We'll begin to see that now. I'll take questions, Andy. There's a lot in the report. There's a lot going on in terms of, you know, all the aspects of operational performance we look at. There's a lot of detail in here, and there's just a lot of activity, a lot of things driven by COVID, winter pressures, and the like.
Okay. Firstly, I would like to thank you that you've now got the performance against our peers locally as well. That's very helpful to see how we're doing against Royal Surrey and SASH across a wide range. I think that's really helpful. I was just going to give one, and I know you've got it in hand. I know David has explained, but the thing that I would have expected is when we open CAU and AECU, of course, to have an impact on our for our performance, and yet it hasn't. It's remained very kind of flat, or even gone down a little, hasn't it? So is it that we've still not got those processes in place yet, and is that the work in progress? I know David did mention some of that earlier.
It's definitely part of that. It's definitely part of some of the things that have been put in. Some of the things have been put in, and some of them have given us a level of resilience that other organisations haven't had in the system. So whilst we haven't gone into Opal 4 as much as other organisations have, and our performance hasn't fluctuated as much as some of the others, so it's given us a level of resilience. However, there is a lot of work to do. There's work, so the team, the Triumvirate and the Educate team have done an enormous amount of work, but there are some key things that we need to enable some of this to go forward. And so there's some of the investment that we need to put in around the teams and the process in CAU. So it's that CAU investment piece that Tom and I are working on. There's the other things that Tom's described today around the criteria to admit and the flow through, and the work that we're doing with the consultant establishment. So they are key foundations to a lot of the improvement going forward.
Yeah, okay, thank you. Questions for James? Marcin, did Modern Healthcare have any sort of comments on this report when it came? I know you're speaking for Merrick today.
Pam, and I expected you to ask me first, as you did Jane, but it's okay. Yes, I mean, I think that we would say, well, basically our view is that you could see the COVID surge having an impact on our performance, but we were pleased to see all the improvements in particular in the areas that we've been concerned about, which is in endoscopy. So that was excellent to see. And as you did hear, we were very pleased that James did add a chart on our performance in the system, and you will notice that we are either first or second in every criteria. But I suppose the downside of all of this is it's taken a lot of money and resource. Insourcing, outsourcing, bank and agency is very up in order to achieve this level of performance, which, whilst we're not meeting all the standards, we are certainly doing better than most trusts in the country. So that's the issue, is longer term, how do we sustain this level of operations when we won't have the money? And I'll just back up James's point on radiography that you'll hear in audit committee, which was this has now been escalated as a corporate risk to catastrophic, that the lack of radiographers is now going to have a very big impact unless we can resolve that workforce issue. So that was the feeling of Modern Hospital, which was a thumbs up, but it's expensive to maintain this level of performance. So thank you, James and Chairman.
Thank you. And I didn't come to you first because it goes to 2 committees. I got caught between 2 stools as to, and therefore.
Oh, very fair. Very good point. Good rescue, Andy. Good rescue.
Ah, you see. No flies on me. Chris Catley.
James, thanks very much for that. Yeah, no, it is good to see some encouraging trends there. I just wanted to drill in on the stranded patients. There seems to be a real big spike, particularly in those over 21 days. I was a bit concerned about that. I'm not sure whether we mentioned this in quality committee or not.
Yeah, so it's one. So there are a couple of reasons for this, and well, probably 3. But the the reason I keep talking about the COVID situation is because it's making it really slows things down.
The hospital flow,
so
yeah.
we've got 150 beds are in some way stalled due to COVID at any one time. So we have then, with the whole system that we have of getting people home, getting people packages of care at home, getting them supported placements, nursing homes, care homes, it all grinds so much slower because there is a hesitancy around people with COVID, and we do tests and we have to, but you can understand that hesitancy around transferring people with COVID around the health community. So that does cause us a challenge. That relates to, we only got 70 patients is 2 wards of patients of COVID that is in the system, plus another 2 wards at least that are effectively with isolating patients. So that is definitely causing a challenge. We also have an issue with some of the staffing in therapies, which we know is causing a challenge to pathways. So our therapist position is significantly challenged and is affecting that pathway through. So they are the 2 key factors, Chris, that are driving this at the moment.
Okay. But that spike, over 21 days, can you just explain that a bit more? I mean, it's sort of to 120 and the target is less than 52.
The target's an internal target, Chris. Right. So, yeah. But I mean, it is not what we want to see, is it? I can't really give you any more explanation than what I have. We don't want to see it. This normally relates to the sickest and illest patients in the organisation, or patients who need a lot of support, and the patients who need support from other organisations. So whether that's Surrey and Borders, our mental health partners, our social care partners, all organisations are under pressure, and it all sort of gravitates where the patients are with us.
Yeah, sure. Thanks, James. Cheers.
Can I follow that up, James? With that, Chris has got a good point, and I reflect back to my work I did for On Risk with the system. Is this not an escalated risk that the trust should escalate to the system to say that unless the system helps and cooperates, the stranded patients will continue to rise?
Yes, and we do that, and there's a lot of work going on at the moment around. So there are 2 places we do that, through the ICS and through the local alliance. There's David's got his hand up. There's lots of work going on with rebasing beds, with beds that we have in care homes that we block purchase. There are lots of things that we're doing. Should we just let David come in first? I didn't see his hand there.
No, I mean, I think you were saying exactly what I was going to say, James, that we are talking to the system a lot. The system's under huge pressure. One of the initiatives that Jack and the system are working on is securing 30 more nursing home beds to act as discharge to assess, which allowed the flow through. But the COVID, as James says, interferes in so many things, and clearly there's concern from residential homes, from relatives. If their relative has had COVID, they don't want them back in the home or the residence or the nursing home, because they're concerned. So there's lots of things that are stopping it. We escalate all the time to the system, and we're trying to work with them in a really constructive way. I mean, you mentioned the piece generally, Marcin, which is the cost of keeping the delivery and the performance where it is huge at the moment in every area. And Simon will remind us that during the pandemic, we've increased our bed stock by 120. And clearly that is to take up some of the gap and the shortfall in the community, and some of it's to take hold of the fact that we're living through a pandemic. And we do need to review all those things and all those places where we're spending money to work out, is there a better way of spending that additional funds? And that's the same on the elective pathway. I think you're absolutely right that insourcing and outsourcing has benefits, but it has costs, and it causes pay inflation costs as well throughout the whole system if we carry on doing that. So we are having lots of conversations, Marcin, but it's every organisation, the system is struggling.
Thanks, David. Anything else for James before we let him go? Okay, thank you, James. Oh, Jane.
Just briefly, the Quality of Care Committee, one of the areas we wanted some further information on is the performance in the emergency departments, because we know there's been a lot of investment in different structuring and different areas, and it was something that we also picked up with the division. And so we would just like to understand how our new model is going to influence and hopefully improve matters going forward in the future. So we've asked for some assurance around that going forward.
Okay, no, that's very helpful. Okay, thank you. Thank you, James. Now we do come to Marcin. Anything you want to let us know about the minutes of the Modern Healthcare?
Well, January and February were approved as stated, and I kind of said our piece. I mean, this month it was really about looking at both Louise's workforce report and James's operational, and saying, you know, and then Simon's finance report, and it all go, because basically we got a lot of money now and we're throwing through a lot of people and agency and bank to deliver it, insourcing, outsourcing. Our numbers are coming down, but around the corner the money drops so significantly, which I don't know if we have on the agenda, but you know, we're heading for a massive deficit. We're still waiting for the detailed plan from Simon, who is still discussing it within the system and the region. But we are now having to then focus the next few Modern Hospital meetings on how we achieve the efficiency saving, the SIPs. We need to start really getting plans in place to deliver those efficiencies, and we need to see how we're going to close that loop. And actually, we're still waiting to hear from the system and national, because we don't have any other more options, or we have to start talking about what we can't do. But
Okay.
a 23 million pound hole is big.
Yeah, and I think that's a great segue, actually, Marcin, because although not strictly on the agenda, I think as it's open board, we need to let Simon have a couple of minutes just to kind of put on record where we are this year.
Okay.
And actually the discussions that are ongoing with the wider NHS around next year's funding. So just a brief summary, Simon, please.
Okie doke then. So our first draft submissions, which went in a week or so ago, proposed a £23.2 million deficit for the coming year. That's on the revenue side of things. There's some opportunities to improve that are currently being discussed with the system. At the moment, the money that we've been confirmed is about 1.7 million extra, so that would reduce that 23.2 to whatever that is, 21.5. So kind of marginal movements. Let's describe it that way. There's a lot of work going on, and Ian's on the call or this morning as well, representing the ICB. So there's Cobham, another day next week, the whole system together discussing our collective progress, I guess, on meeting these challenges, because we're not alone in this. I won't quote all the other organisations' numbers, but there's similar challenges across the whole system at the moment, essentially. So we've got about, what have we got, 3 weeks, nearly 4 weeks to come up with improved plans. There has been, though, a lot of discussion with the centre, particularly around things like cost inflation, the COVID costs and assumptions. And I think our view of the world looking forward has changed a lot from the assumptions that were given to us sort of earlier in the planning round as well. So we need to draw some of that out. But I do think there is an underlying challenge across the whole system that we're unlikely to close in the amount of time that we've got left. So we'll see where we get to over the coming month. Obviously, with the board, we've got a number of calls scheduled and available, really, haven't we, to sort of pick up on our progress. But yeah, the challenge is to improve that position as much as we possibly can, I guess. Okay.
I thought it was important to have that out in open board, just so it's minuted. And there are, as you say, Cobham 3, which is, I think it's at Reigate, confusingly, is next week. And I know our chairs have got a call with Ian on Friday as well. Okay, we will move on in the interest of time. And Aaron, On the People Committee minute.
Thanks, Andy. So I'll take the minutes as read and just bring out some salient points. I think the most important thing to discuss would be the workforce report, which particularly pulls out the 4 risks from the BAF and looks at the issues and mitigations for those accordingly. The paper notes improving vacancy rates. Agency, for example, was noted to be a little bit higher, although expected given services ramping up. Absence and sick rates relatively stable, although with a peak in December and January due to the Omicron variant, which we expected. Of note, the committee noted that the mitigations in things like for the recruitment, looking at ideas like overseas recruitment, were in plan, but there are some issues with respect to finding things like accommodation for those individuals. And there's a piece of work being undertaken for improving healthcare support worker recruitment and retention. Of note, the staff survey had a return rate of 55%. I think that's on today's agenda, which Louise will talk through afterwards. And the committee noted that the wellbeing scores had improved due to trust interventions last year. The Wellbeing Centre in St Peter's, for example, had great feedback and strong usage. Other interventions in the plan, including mental health first aid training, for example, were noted, but the committee overall realised and accepted that there's more work to do in this space, given that the workforce morale and is still kind of reeling from the effects of the work intensity and difficulties from the pandemic. In a similar vein, sickness reasons due to stress and anxiety were on the upper end of baseline normal. Something to note given the importance of mental health of our staff. And a flexible working survey is currently being promoted across the trust with an understanding of additional offers that could be made to help work-life balance to address those issues. The committee has also been continually appraised by the progression of the talks in the ED, as David already spoke about earlier today, with an aim landing a result by August, with consultation closing in April, which I think we spoke about already. And I think those are the main things just to bring out for everyone's attention.
Okay. Thank you. Any questions on anything on the People minutes? No. While you're on, Aaron, obviously we've got Louise on in a second on the National Staff Survey. Obviously you've had a look at that as the People Committee. Anything you want to pull out as the NED chair at the moment?
Yeah, I think the return rate I think is positive. I still think that could be improved, but overall I think the general trends are in the right direction. But I'll leave Louise to go through the detail and perhaps follow up afterwards.
Okay. So, Louise, you're on with the staff survey, please.
Yeah, just sorry, I did put my hand up, but quite late in terms of the previous item. I suppose the other thing just to mention, and 2 months ago feels like a lifetime ago, but in the January People Committee, we did spend quite a lot of time looking at the issues in relation to the mandatory vaccine deployment and the impact that would potentially have on workforce supply. And as you know, we were then told sort of within a few days of that meeting that the government had rescinded the mandatory legislation. But it's just worth the board noting that, because obviously the minutes do talk to that. And as a piece of work in itself, it was a considerable amount of work for me and my team that actually beared little fruit. So useful just to reference that for the board as part of those minutes. Aaron's got his hand up.
Yeah, Aaron?
Yeah, sorry. Just to follow up on that, sorry, I should have mentioned that in the previous committee, we spent a long time talking about, didn't we, Louise, and the amount of work that was going into pulling all those reports on and chasing up and improving those figures on those mandatory vaccinations, only for it to not be used should be recognised. So, thank you to the teams that were involved in doing that, because I recognise that had quite a high work intensity at the time.
Yeah, thank you. As I say, 2 months ago feels like a lifetime ago. So I'll go on to talk about the staff survey. Board colleagues will have had this paper since Monday, but obviously members of the public that may be looking at the papers will only have seen this yesterday. And the reason for that is the staff survey was only released yesterday nationally. So I've also spent the last 24 hours reviewing the national response to the staff survey this year. So not a huge amount of time for me to reflect on that, but I have been able to do that. So I'll just feed some of that in as well. So as Aaron has said, we've got a reasonably good response rate this year, which is always quite good in terms of then understanding how statistically significant the results are. Although I think it's probably still useful for us to do some further work on that. And as a survey overall, and having had a chance to have a look yesterday at the national results, I would say we're pretty average in terms of these results. So for the majority of the questions, for the majority of the indicators and themes, we are slightly above the national average for acute and community trusts, and that's the peer group that we are benchmarked against. So always useful just to look at what that means. But I suppose the sobering message is that almost without exception, all of the scores have reduced this year. So if you put that into the context of what I've just described nationally, you can see the national picture is a deteriorating picture almost entirely in all of the domains of the staff survey. And you know, it's obvious from the conversations that we've had today, you know, we don't have machines running this organisation, we have people, and people are tired and have found the last 2 years overwhelming in terms of the expectation of them. There is one area nationally where the staff survey has improved, which is the area around staff feeling that they are supported by the trust and by their colleagues. So, you know, that is something to hold on to, the fact that the feedback that we're getting is that people are valued together as human beings responding to a really difficult time. The most pressing thing that came out of the national survey, which again I think we would recognise, is the need for us to continue to invest in the workforce supply and to increase our staff numbers. And that is against the backdrop of, I just looked at the data today, there's 46,000 more staff working in the NHS than there was this time last year, or this time when the survey was done last year, so November 2020, so 46,000 more staff. But obviously, the workload has changed, the pattern of how we work, the issues in relation to COVID and what that's meant in terms of patient flow, as James described. A lot of those staff will have worked in the vaccination centre. That is another piece of work that we've taken on top of everything else that we deliver. So one of the really significant things that came out of the survey this year was that piece around addressing the shortage of workforce to be able to deliver healthcare today in the format that we've got today. And so just to go to the Ashford and St Peter's results, and you've got those in front of you. The important questions that we always look at are those in the engagement score. So there's 9 questions that are made up of motivation, involvement, and advocacy. And one of the questions in particular that we're always quite interested in, obviously from a recruitment and retention perspective, is that question around, is the trust a good place to work? And our results did reduce from last year quite significantly, sort of by about 8%, but they still remain 4% above the national average. So that sort of is one question and one indicator does sort of just talk to the issues that we face this year. And actually the Health Service Journal, if any of you looked at that yesterday, mapped every acute trust, every mental health trust, every community trust against that one question and ranked them. There's some of the things that I've just pulled out there in the introduction around key findings, and table 1 I think is quite a good one for you to be able to look at, because that's our top 5 scores. And again, as you can appreciate, I was writing this report before yesterday, so this is against the PICA average, which is the company that we use to administer the survey. It's not against the national average because obviously not everybody uses PICA, but you can see there our top 5 scores, and interestingly, our most improved scores. You know, it's good to see our most improved scores, including the questions around bullying and harassment, because we know that, you know, that continues to be a theme that we are interested and concerned about. And if I go on to that section, if I leave out section 2 for now and just table 2 and just talk about triangulation against the CQC findings. So obviously there's a description there in terms of how the organisation has had to adapt, and in particular that piece that we got in terms of feedback from our surgeons and anaesthetic teams in particular about feeling disengaged and disenfranchised. So I've had a look at the questions around involvement, and actually it doesn't feature in one of our bottom ranked scores, so that is good to see. You can see on that next bar chart that actually opportunities to show initiative in my role is one of the engagement scores that has actually increased this year for Ashford and St Peter's. So good to see that. The rest of those questions that make the engagement score have all reduced slightly, but as I've said, continue to be above the national average. So take some time when you can just to review those. And actually our overall engagement score, I've said here under paragraph 10, is 7. Actually, when the national results were published yesterday, ours has gone up to 7.1. So we were 7.2, we're now 7.1. The national average is 6.8. So you can see again that there has been a reduction in that score nationally. So the 2 bar charts that follow that paragraph are obviously the ones that show you the detail. For the first time this year, the staff survey has been reconfigured under the elements of the people promise. But again, the benchmark report that shows me that in simple terms was only published yesterday. So you forgive me for the way in which I presented it in this paper. I had to do this manually by going through reams and reams of data, honestly. But anyway, I won't dwell on that. What I did do was I tried to pull out under the headings of the people promise where I thought our top and bottom scores were, and you can see the way in which they're worded under the different elements of the people promise. If you're interested in understanding a bit more about the people promise, then I have shared that with you before through the transformation work, but you can also just go into Google and Google people promise, and that will tell you what all the elements are. Again, really good to see things like motivation subscore as one of our top 5, and actually interestingly the negative experience subscore. So I looked into that in a bit more detail, and that talks about pressure to come to work when unwell, workplace violence, workplace injuries, and workplace harassment. So all of the things that we are concerned about when we read our anonymous freedom to speak up whistleblowing claims haven't come out in the staff survey. So whilst I'm not belittling the people that make those reports anonymously, it doesn't feel like it is a significant issue across the organisation. What we do have is definitely some issues that have come out which, you know, I would say show a capacity issue. So appraisals is probably our lowest score, and actually it's the one score out of everything in the staff survey that is below the national average. So our capacity to be able to do those appraisals has always been a challenge for Ashford and St Peter's, but during the last 2 years has clearly continued to be so. And our opportunity to give people chance to learn and to think about career opportunities is another area that did come out in the bottom scores. We've heard a lot about burnout, and for this time in the staff survey, it was the first time with which they asked a series of questions under the wellbeing section around burnout. And whilst it's an issue for many sectors, we know that it is an issue for the health service sector. It's a new measure, so it's difficult to really know what to think about the score because we've got nothing to compare it to. But obviously, it's important that we take note of it because that drives a tired workforce, you know, will ultimately drive a potential issue around retention. I've talked about bullying and harassment already, you know, the one area that I did pull out just so that you've got a bit more information on is the question that we ask around are relationships at work strained, and this is the response that we had from that question, which again is difficult to know what to conclude from it without being able to compare that to previous, but we will continue to look at that, obviously. I won't take questions, I'll just carry on if that's all right, Andy. I've just finish the presentation and then take the questions
just carry on.
Yeah, okay. Retention, so again, if I go back to those bottom scores, one of them was a question around morale, workplace subscore, thinking about leaving, demands on your time and staffing. The looking forward to going to work score nationally has reduced from 59% to 53%. Our score has reduced slightly, but is still at 59%, I think it was, so it's still above the national average. But obviously, people thinking about moving jobs is an important question for us. It's an important metric, and it's been really important for us to look at that question in particular, you know, with the divisional team, so that they can identify areas that they may have previously not recognised as being an issue. And I'll give you an example of that is my department and some of the other corporate departments. If you look at that question compared to previous years, there's been quite a significant deterioration for us. So the pressure of having to change how the corporate functions work to enable the clinical functions to change how they work has had a long-term impact on those teams as well. Inclusion and having a positive and healthy and compassionate and inclusive culture is one of our ambitions. We have recently increased our resources so that we can try and understand pockets of the organisation where difference leads to either inequity or differential experience. And we've picked out of the survey some of those themes, but also some of the things that we're doing, which we hope will start to have an impact. So I'll just talk to one of those. We quite often see that in the questions where people tick the box that says they would prefer not to say what their gender or sexuality is, then that then corresponds with them being the unhappiest in terms of their answers to those questions. And so that definitely poses some questions around, are people able to be themselves when they come to work, and are there issues in terms of people not feeling comfortable being themselves? And so the work that we're doing around the Rainbow Badge scheme, which I said before, but I'll just reiterate, we are one of only 40 organisations in the country that are doing this work. So what I hope is that this will give us some really good insight into how it feels to work at Ashford and St Peter's and what are the opportunities for us to improve. So I've just detailed there some areas for improvement. So that piece around staffing is one that came out of our survey, but also that really important question around, you know, if a friend or relative needed treatment, I'd be happy for the standard of care. So that's one of the engagement scores. You can see the bar chart from since 2012. Our scores around that question, which is a really important question. This is what we do. We deliver healthcare. So for us to work in a trust where we would recommend it to our family and friends is a really important metric for us to look at. And you'll see the bar charts under the staff engagement paragraph show a really kind of an improving trajectory right back to 2012. But actually this year that question has reduced, and there's less people in this organisation that feel that they would be happy for their friend or their relative to be treated. I've set out in the final section some priorities for next year, and I've also just in the conclusion given you a quote from one of the divisional teams. So what I haven't said already is that we've had our results for quite a long time. I mean, the way in which the survey works is a bit curious. We get them in January. We're not allowed to publicly talk about them until today, which is the last day of March. But actually, we haven't just sat there and looked at them ourselves. We've spent quite a lot of time sharing the detailed plans, and they drip feed the results to us as well. So as they drip fed those results to us, we've shared them with the divisional teams. We had a whole hour at Tech last week where we got the divisions to present back to us what their reflections had been from their own individual surveys and what they were committing to working on this year. So we have those plans that the divisional teams are working at, and we will no doubt revisit those plans with the divisional teams during the the executive and divisional performance review meetings that we have with them every other month. So I'll pause there because I've talked for quite a long time, and obviously the information that you've got in front of you is quite a lot of data. So I'll just pause, Andy, to take any questions.
Yeah, thank you. And I think, you know, there is an awful lot of data there, and we've seen obviously some of it before, but we probably, I certainly need to think about it a little bit more as well and take it away. But a good explanation. Thank you very much, Louise. So Aaron was first.
Yeah, not a question, Louise, but just a couple of builds on that. I think, I mean, Louise, you mentioned at the end there, question 21D, regarding whether patients staff would recommend being an engagement score. I think it's probably important for people to note that if you look at the other questions in the most declined scores, for example, enough staff at organisation to do my job, and also I don't often think about leaving the organisation. I actually think that they're inextricably linked, those questions and the answer to those. And the positive thing about that is I think some of the efforts that we've already got in plan through the committee and what was reported to the committee are actually probably will make a big difference to all of those in one hit with some of the measures being taken. And then the other thing I was going to say, you know, for example, the rainbow badge scheme that you mentioned being one of many. The other thing I was going to say was that the results obviously came out in January, and we're talking about this now at the end of March. So there, you know, there's been measures that have already taken place in that time that probably would have already improved some of these schools already. So I think that's trending in the right direction.
Thanks, Aaron. Dami.
Yeah, I think Aaron mentioned some of it, but thank you, Louise. Thank you for the report. Certainly the report that came to the People's Committee last week was very different to this one that you've prepared today. And there is a lot of data, and there's even more data on the website in 145 pages. So thank you for your summary. I think what you didn't do was to praise the staff and the effort actually of your team in their response to the well-being offers that the well-being offers that there have been, because those were really well received. I don't think that this report kind of highlights that, and as Aaron has said, it's work in progress, and hopefully we will start to reap the fruits of some of that work. Of course, you highlighted a lot of the points. You highlighted the issues around safe working, you highlighted the issues about the engagement, you highlighted the issues with motivation and career progression, and I'm so looking forward to receiving more detail about this cultural transformation program, which I think will improve a lot of these things. But thank you.
Thank you, Dami. Chris Kane.
I think I just want to build upon that. It's a question not to be answered today, but I think you hit the nail on the head by stating that we all need to try and figure out how to work smarter rather than harder. And I would also echo that you and your team seem to be doing a hell of a lot of work over the last period. So keep that up. But all of this stuff is connected. We've heard earlier about estates issues, which are inhibiting performance and inhibiting our effectiveness. And I would urge the executive team to make sure that you understand all the connections and see how they all play out. It is always about people. We can never forget that, but it's all connected up. So look forward to seeing how the cultural program comes on, and how you focus on the behaviours and attitudes. I think they're pivotal. That's my 2 penny worth. Thank you.
Thank you, Chris. David?
Yeah, it's just one thing. I mean, it's a huge amount of work, Louise, and as Chris says, it's all about people at the moment, and actually understanding that all our staff are not feeling the same, and we've got to work out the differences into the different parts, which will take some more work. The other bit I just wanted to draw everyone's attention to was the other survey that has come out, which has shown that the biggest drop in NHS satisfaction that we've seen, and it's at the lowest level that it's been since 1996. And the reason I bring that up is because we can quite understand that. We've listened to the performance report, we've listened to the whole of this board is about the strain that the NHS is under in meeting the demand. But I just think the reason I bring it up because the impact on staff of this kind of survey will also be felt as well. And so I think we just need to make you aware of that. And really early on in the pandemic, when the community and the public was so behind the NHS and the absolute joy that the staff felt with being so supported, I think we always knew that we would come to a much more difficult time, and we just need to be aware of that. And I think we do need to make sure we help with the messaging as it goes out from all these things. So I don't know if people have seen that recent report, but I think it is going to land and cause us some impact on our staff going forward.
I mean, impact on staff and obviously on our political masters as well, because they will act on that. And the big two messages were access to GPs and access to elective services, weren't they? So it's, and I don't think the NHS in general or the politicians have done a good job on sending out the message that the NHS cannot recover from COVID overnight. Public rightly demands good service. The Treasury will demand that our money is spent wisely, but actually, I'm not sure out there in the public that the knowledge of the pressure we are still under as a result of COVID and other things is known at all. It's why can't I get my appointment? Why can't I have my operation? And all these are reasonable things for a person in the public to ask for, but not really being explained at the highest level, I think. Marcin.
Thank you, Chairman. Thank you, Louise, for an excellent paper. Just to plea, really, that, and I'm sure you've already thought of this, but when you communicate this to the staff, I think it would be useful to show the things you're actually doing to change the culture, to change some of the people over process, to say what we say. It's enough to say we believe in appraisals. This is how we're actually going to make it time to make it happen. I think you've got to show staff the actions you're actually taking to address the areas and I'm sure you've thought about that, but your comms on this needs to be action oriented, looking forward.
I think it's the you said we did, isn't it? It is about that. We're running about 10-15 minutes over, so I'm going to have to move us on. But thank you, Louise. That was a really comprehensive report. Very, very helpful. Chris, can we take your digital committee minutes as read?
Yes, please. We can. Do you want me to draw up a few things, Andy?
I think given the time, I think I'd rather kind of go to your the annual report, unless somebody's got any questions on the minutes.
No, that's fine. No, it's really just to make sure that, I mean, I guess the issue is around people as well, Andy, and I would make the point that there's a lot of work going on in terms of alignment with the ICS, and that's really important, particularly around areas like data. And it's involving other areas like council and the police, and we're just making the point, more and more requires extra work on staff, and although these things are really, really important, just mindful that digital is an enabler of everything, and therefore we need to be mindful in its prioritization
and an investment to make sure we have the support, the people in their actions, to make sure we have the right resource to actually implement it as well. So there was a lot around there. There's work on strategy. I think if we just go straight to the annual report, if there's no questions on the minutes, the annual report is obviously about a review of everything we've done. And I've got to say, there's just been a huge amount. Obviously, safe care is the major priority for us, and the landing of the electronic patient records and clinical and corporate systems for both Royal Surrey and ourselves, which has been going at pace and has been an enormous amount of work for people in addition to their everyday jobs, and I think we're mindful of the huge effort that's been put behind that. It's due to go live in May. It's on May the 16th. We'll come on to that after this because I know Simon will want to say more. But I guess we've had 5 meetings on a quarterly basis. A lot of them have been virtual, interestingly, and I think they've been very effective as well. And from that, a lot of action has been taken to progress many programs. And I think we should take note of the fact that the digital program steering group has done some amazing work in coordinating effort and activities in Ashford and St Peter's in terms of all the activities around digital, and I think that's to be commended. But apart from that, I think I'd just like to sort of take questions if there's any observations or any issues around it. But apart from that, I think it's all gone pretty well in under the circumstances.
Thank you, Chris. Questions for Chris? One that struck me looking at it was we've talked, about RotaGeek and the that's a transformative thing, yet it isn't listed on our list, and I'm not quite sure why that under your transform piece.
Yeah,
because it's.
I think that's the way Louise is. This is just part of it, actually, Andy. It's much bigger than this.
That's what I thought. Yeah.
Yes. So it is on it. It was on it. It's landed basically. So this is on things to land in the future. I mean, RotaGeek is gone, hasn't it?
Well, it's still to be rolled out to the medical workforce, of course.
To the medical workforce, yes. I think this is showing us a snapshot, Andy.
Okay.
And that, as I say, if you look at the whole digital program, it's much broader than this. But this is sort of giving an indication of where we are on the important ones. But obviously, RotaGeek is one that's landed already, but it's got to be rolled out later.
Okay, John.
Well, I guess mine was actually in relation to Protect and the amber rating in relation to things like infrastructure resilience, secure backup and things. Presume we've got a program in place that's going to be dealing with that over time, but to be in sort of position is not a great position.
Absolutely, there has been some issues around this is the new data center and resilience of data. John, there are plans in place to address all of these and bring them back to green. I don't know if you want to say any more, Simon.
Not in the public session on that one.
Okay.
I think.
Okay.
I mean, I can talk about the wider challenge, but nothing specific, if that's okay.
No, that's fine.
So one of our issues, as just an example recently, has been patching, and the speed at which new patches have been rolled out to increase cyber resilience has led to some problems with interactions with the rest of the infrastructure and the estate. So they've had to be unpicked and then rolled out again as kind of one example. So yeah, there's challenges on all front to keep us completely resilient, and I think given the wider risks, Andy alluded to them earlier, in terms of cyber challenges from China or Russia or wherever, really. Yeah, it's something we need to watch on a constant basis.
Yes, you're right, Simon. I should have said, John, for those who are new to this forum, there is a closed and open session. The open is really around strategy, big transformational projects, and also those other programs around the maintenance and replacement of our systems. But on the third area around cybersecurity and data protection, it's an area we consider in the closed committee rather. So that's then discussed in the closed board. Yeah, so we have to be a little bit careful, especially as Simon says, in terms of the wider global issues that are going on at the moment.
Absolutely.
Okay. Right, let's move on. Thank you for that, Chris. Let's move on in the interest of time. Simon, do you want to give a brief update on Surrey Safe Care?
Yeah, so all really quite exciting at the moment. We are 45 days to go. So what's that? Just over 6 weeks. You can. I'll take the paper as read, but you know the first chart in there demonstrates that we're kind of finishing the technical review side of things, and we're entering our full dress rehearsal next week with the operational teams, which is good news. I think there's probably 2 common themes that come out of the paper. Most of our challenges now are either around the people or around our own resourcing. The people challenges are simply the pressures of trying to do everything really at the same time, but you know training, it's around booking onto courses and time for e-learning in particular. Our course booking, we're probably at 80% at the moment now, but our e-learning, we're struggling. It's something like 10%. There's a huge amount to do over the next 6 weeks, and I guess individuals making time to do that, or the organisation creating the time to do that, is really where that challenge lies. Also, you see it on the smart card side of things, just getting photos from everyone, or the pressure that the dress rehearsal process will be under the next 3 weeks in terms of attendance and availability and all those sort of things. So there's a kind of common thread there. I think the impact of that is kind of how bumpy a ride do you get when you actually go live. Clearly, the closer we can get to 100% of people being trained, familiar with everything, then the smoother that go live is. And you know, there's ultimately some kind of trade-off if you don't quite get there. You know, we will face more challenges. We'll need more floor workers to cover them. Those sort of issues, Andy. I guess the other issue is just the central resources in the team. So we're under huge pressure in terms of the amount of kind of certain go lives that are going on locally, the amount of or the availability of highly skilled staff to be able to undertake this sort of transition. So we're constantly juggling. Like everyone, the teams are tired. We've heard that, you know, all throughout the meeting, haven't we? And it's no different for those sort of teams. You know, there's a few hundred people that are working on that, and if we lose 20 at the margins, it has a material impact, really. So that's kind of the hard bit. Nevertheless, we are dragging the horse to water, and we are making it drink, I think, is probably the kind of summary, just to use that particular saying. But yeah, it's the critical time really for us now as we drive forward, Andy. I think I'd say there's clearly a lot more detail in the paper. The Joint Digital Committee with Royal Surrey looked at it earlier in the week, I think Tuesday. So it has been through those kind of scrutiny challenges as well. Yeah, processes. Sorry.
And you know, you summarised it well. You know, we are in the muck and the bullets at the moment, and it is very tough for people to carve out time to do the training and go and get their smart card. And I was over in Chertsey House yesterday. There was a queue out there for smart cards, so that's good in a way. But you know, it's tough, and you're right. Other trusts that have gone live with lower numbers of people trained have struggled. So the higher, the better. But yeah, it's a good report. Any questions for Simon on that report? It's tough. It's tough, but we got to do it. Got to get there. The benefits are huge.
It's worth it in the end.
Yeah. Okay, good. Marcin, anything you want to bring our attention to on the audit minutes?
Not from the minutes of the last 2 meetings. I'd just like to bring your attention to the last one because it's the end of the financial year. The good news is we met our new external auditor, KPMG. They will now start to plan the audit. As you know, we've had an agreed extension and we will be needing to have a board meeting and an audit committee in the first week of September, and that's being organized. The BDO is finalizing their program of internal audits. Sadly, we've had no substantial assurance statements this year, but the good news is we've had better implementation of recommendations. So well done to the executive on that. The one audit that had limited assurance, which is the lowest rating, was the Dolls audit. And you already heard Ellen talk about they presented their update to us on the implementation. And I'm pleased to see how seriously they are taking it. And I know that's going to Quality Committee as well. We did have 2 deep dives and assurance presentations by Digital Committee, Chris and Simon, and People Committee, Aaron and Louise. Both were excellent presentations, very engaging. And I think what we came around from both of those was a conversation of, once again, about how we link KPIs to the future and to the performance so that we have a better story, and whether we need to adjust and refresh the risks. And I think that's something that all sub-board committees will be charged with from the new financial year. And lastly, we had a new agenda item on our committee from our new terms of reference, which is an assurance piece on the governance and controls around the FTSUG, the Freedom to Speak Up Guardian. They presented a tool, an NHS tool, which rag rates your governance and your controls around the program. I think they were pleased that they found the tool and that we had a good program and assurance around what we do well, and it gave them some ideas and new things to bring to our attention. So that was excellent. And the last piece we had from Sal was the latest corporate risk register. And as I mentioned, there is a new corporate risk on there, which is the catastrophic risk around radiographers, and they've got an action plan in place. It was an excellent and engaging meeting, and I actually got someone who said it was fun. And we welcome John to his first audit committee meeting. Thank you very much.
Yeah, thank you. And, thank you, Marcin, really, for reinvigorating the audit committee. And, I think it's in a very different place, judging by the remarks. I mean, the person who thought it was fun, he obviously needs to go to the doctor, but it's in a really different place. So thank you for that.
You're very welcome. Thank you.
Okay. Assuming there's no questions on that, we will move on. And again, in the interest of time, anything on the trust? There's 2 things on the trust seal, Simon.
Relatively straightforward. You'll see some building works at the front of the site, which was the first one, which is the power supplies through to the temporary Abraham Cowley Spencer Ward, is it? Replacement, which is just at the bottom of the site. And the second one was all to do with the, again, we keep getting these, the West Site land sale. So there's this one, 129 and 130. It's not on here, it'll come next time. But they were both signed, and we have had now the final payment of the land sale proceeds to us. That was 6.5 million that came in yesterday as well. So all of that is in the bank. The trick now is to get it out of the bank and spent on the hospital somehow. So we'll work on that front.
Right. Okay. Thank you. Now, on the principle of saving the best to last, we've got Ian Smith, as I said at the beginning, who's the chair of the Integrated Care Board, and he's going to give us an update on things from that level. So, Ian, I hope you're still with us.
I'm still here. How long do I have, Andy?
We're thinking around 10 minutes. Is that all right?
Yep, that's fine. I'm happy to go on a bit longer if people want to hang on. That's up to you, Chair. Do you want to?
I think if we can keep it, because we've still got questions from the public to go.
Yeah. Okay.
Thank
All
you.
right. Well, firstly, thanks for inviting me to the meeting. It's a high quality board, clearly, and you're hitting all the right issues, the workforce challenges, quality, and I was glad to hear, Simon, about the numbers. What I'll do, Andy, is start talking, but I'm very happy to be interrupted because I'd really like to answer your questions rather than go through. I can't see the hands, Andy, so if you just interrupt me as I'm talking.
I will do.
If anybody has anything to say. Very quickly on the sort of the legalistic side of all of this, I think the ICB and ICP, which are the 2 parts of the integrated care system, are moving along well. We have a shadow ICB, and it goes, it's formal, hopefully on July 1st, as Andy said. The ICB is the NHS statutory body, so that covers the whatever £2 billion budget that we have across the system for the NHS. And that's complemented by the Integrated Care Partnership, which is the broader context of people's daily lives in terms of the local authority, voluntary community activities, education, housing, and so on. That is chaired by Tim Oliver, who's the leader of Surrey County Council. But we are very close together in terms of ICB and ICP are 2 sides of the same coin. And I think one key part of the ICS is that integration with local authorities and looking after people's broader life outside of acute care in the NHS. The Marmot report of 2010 was hugely influential in making us understand what it means to keep people healthy and well. And as you've all heard, only 20% of health is determined by what happens in the NHS. The rest is about lifestyle, housing, social circumstances, life chances, and so on. So getting onto the ICB, it's clear that the NHS system is under huge stress and has been for many years. The patient pathway through the system is at best disjointed and at worst hazardous. And I think the people who work in the NHS and social care work extremely hard, but I think all of them would say, you know, it's very, very difficult given how clunky the system is to do the best by their patients, which is why, you know, everybody works in the NHS and in social care. So I think we have to fix a system that really doesn't work despite the huge dedication of the workforce. I think we need to make it better for patients to go through it, and better for people to work in it, and make a system that supports health and social care workers rather than make their lives more difficult, and create a system that is efficient as possible in terms of spending taxpayers' money. It was good to hear Simon and Marcin talk about your deficit. We need to, you know, we need to create a system in which we are making it as efficient as possible in terms of the way we spend taxpayers' money. I think fixing the system means the framework we've come up with is what we call the critical 5, which is not new to anyone. I think the difference, though, is that we are going to make the critical 5, which I'll describe briefly, work. I think there's a lot of good effort within the NHS to keep people out of hospital, to get people safely out of hospital, to get system benefits, but a lot of these are ad hoc, underfunded, and rarely sustained. I think the purpose of the ICS is to get these critical 5 that I'll describe briefly, but to make them robust operating models, make them sustainable, adaptive to changing patient and workforce and technological circumstances, but really bed them in there. We know we've had a problem with hospital discharge, frankly, for 60 years. And we still haven't cracked it, as your conversation earlier today. So I'll go quickly through the critical 5, but please stop me and let's have a discussion if that's better. The first is 2 parts. One is preventing people deteriorate in the first place, and the ICP, the local authority, and the community have a very important role in that. We have very high levels of hypertension, particularly in Surrey, actually. Mental health problems have doubled through the pandemic. You know, we've got to get ahead of the curve on this and get to people much earlier in the pathway than currently. And that includes things like housing, employment, education. But if people do deteriorate, and this is still the first of the critical 5, we need to find urgent care pathways or rapid response. That means that they don't turn up at your A&E, at St Peter's A&E. As David and Tom talked earlier in this meeting, you know, your A&E is under huge pressure, 400, getting on for 400 a day attendances. That's not good for you. It's not good for admissions, and it's not good for most patients, for the patients at least who do not need to be there. So we need urgent care pathways fixed, not just good effort, but actually create operating models and sustained operating models that get people to safe places. And if they don't need to go to A&E, then make sure that they don't. And, you know, to do that, I think, frankly, we need to fix primary care. You know, we've just got to fix that primary care. I think 70% of that first objective means that we've got to do better in primary care. And 9-minute appointments doesn't work for patients, and GPs don't like it. Everybody's unhappy. So I think we can do a lot better out of hospital. The second of the critical 5 is discharging people from hospital to safe places. You talked about your medically fit for discharge. Across the system, we average 200 people stuck in beds inappropriately. Across the system, we've got today 320 people who've been in hospital for more than 21 days. A frail elderly person a week in hospital loses 10% of the muscle strength. It's a death sentence. You know, we've got to reduce those figures, frankly, to zero. I think that should be our objective across the ICS. We need, and to do that, I think we do need to fix social care. Marcin, your question about escalating it earlier was spot on. You know, we have got to fix this. We've got to fix the out-of-hospital environment. It's no good saying social care's had no money, which is true over the last 10 years, but we've just got to fix it, despite the problems we've got with finances. The third of the critical five is high-risk care management. Typically in an environment like Northwest Surrey, which is about 350,000 people, there are typically about 3,000 highly vulnerable people. Frail elderly, chronic disease, and mental health are the three biggest buckets. What we need to do is focus on those 3,000 as individuals, put in customized care plans, curated by clinicians, to prevent the bouncing around that occurs currently, and really focus on those high-risk people. And of course, it's the same cohort in that third of the critical five as turn up at A&E inappropriately and who get stuck in hospital. So those first three is a sort of you know, a set that includes the most vulnerable in our society. The fourth is making sure our hospitals work as effectively as possible. And there's two aspects, I think, to that.